Arna.
Good morning, everyone. Thank you so much for joining us today, Sunday, May 21, 2023. My name is Samuel from Oldgate Solution, and it is a pleasure to welcome you all to the World Family Doctor Day Conference 2023. A belated happy World Family Doctor Day to all of you. Thank you so much for all that you do and all that you contribute to the health of our nation. Today's theme is ethical issues in primary care. What a wonderful, timely topic that we have to discuss. And of course, the UWI Family Medicine Program, the CCFP Jamaica chapter, and the AGPJ have put together a wonderful program for you today. Our moderator for session 1 will be Dr. Sophie Abrikian. She is a family physician, and she'll be introducing our panelists as we go through today's wonderful agenda. If you have any questions, please post them in the Q&A for our presenters. We'll be able to accept them chronologically, therefore ask them chronologically, and ensure that first in, first out type of a situation, you know, like when we're heading on the wonderful buses in the UK and we queued up. And of course, if you have anything that you want to just discuss or bring to our attention, please feel free to type it in the chat. So again, it's my pleasure to welcome you. It's my pleasure now to hand over to Dr. Abrikian, and enjoy, have a wonderful day. Dr. Abrikian, over to you.
Morning, everybody. Welcome.
Morning, Sophie.
Hi, Donald. Morning. Okay, so I think we'll just get right to it. We have Dr. Parai first, who's going to start the meeting off with a prayer. Thanks, Dr. Parai.
Okay, good morning, all. Let's bow our heads and let's pray. Heavenly Father, thank you for all you have given us and the many blessings in our lives. We thank you for the opportunity to gather virtually here today to celebrate the World Family Doctor Day 2023, and for the tools and resources that make this possible. Thank you that we can come together as individuals with different gifts, ideas, strength to pursue a common goal. As we begin our conference, we dedicate this time to you, asking for your guidance, wisdom, and support. Help us to engage in meaningful discussion, allow us to grow closer as a group, and nurture the bonds of community, nation, and world. We pray for the presenters, attendees, drug companies, and sponsors, committee members, Secretary Ms. Lynn, and the IT personnel who made this conference possible. We pray for your guidance and wisdom as we listen to the presenters so that we may be receptive to new ideas and perspective and can learn and grow together in knowledge and understanding. May your presence be felt throughout this conference, and may it be a time of fruitful discussion and learning. I ask that you will fill each heart with your presence and grant each mind clarity. Help us engage with material presented and apply what we learn to benefit ourselves and our community, and so help to fulfill the mission of WANCO, which is to improve the quality of life of people of the world, encouraging and supporting development of academic organization of general practitioners, providing a forum for exchange of knowledge and information between members, organization, and between family physicians, and presenting educational research and service provision activities of general practitioners. In closing, may we do as your word says in Colossians 3, verse 17. Whatever you do, whether in words or deeds, do it all in the name of the Lord Jesus. Give thanks to God, the Father, through him. We ask these things in your name. Amen.
Thanks a lot, Dr. Parai. Over to you, Dr. Gordon, with some greetings.
Thanks, Sophia. Good morning, Andrea, for chairing and putting such a wonderful program together. Good morning, Dr. Standard Goldson, Family Medicine Immediate Coordinator of the Family Medicine Program, who is also one of the joint sponsors of the FWD program. Dr. Seni Onanujo, president of the local chapter of the CCFP of Jamaica. Good morning to our esteemed presenters, Professor Al Bailey, Dr. Dingle Spence, Prof. Figueroa, Prof. Winston Davidson, Dr. Karen Carpenter, Dr. Helen Trotman, a most formidable line of presenters. Also, good morning to our moderators, Dr. Sophie Abrican, Prof. Marvin Reed, and Dr. Arna Brown, the ever energetic Dr. Arna Brown. Also good morning to our fellow panelists, Dr. Brian James, MAJ President, Pauline Williams-Green, Dr. Bookall, Dr. Williams-Brown. Good morning to our sponsors representative, to Administrator Lynn for doing such good work behind the scene, and members of Sam, and good morning to Sam and members of the technical support team, and to the sponsors representatives from the drug companies. It is my pleasure to bring greetings on behalf of the Association of General Practitioners. As usual, the association, we look forward to joining with the other groups in putting on this wonderful session. Our heartiest congratulations to the organizing committee for the hosting of another webinar celebrating World Family Doctor Day. We thank you very much for the focus on family physicians, on bringing attention to the work, to the ethics, and to the value of the work we do as family doctors. We also thank you for the validation of the quality of our work, the importance of the work we do, because this is not always appreciated. The title of the panel discussion says it all. Family physician, the heart of healthcare. We are indeed the heart of healthcare, and we need to be recognized as such. And the activities of World Family Doctor Day do just that. The organizers, we know you will have a successful webinar, and we look forward to continuing our work along the way as you go in organizing World Family Doctor Day in the future. Once more, greetings from the association, and greetings to all the members of our audience as well. Thank you very much.
Thanks very much, Donald. And now over to Dr. Trotman-Edwards.
Thank you very much, Dr. Abrican. Professor Marvin Reed, President of CCFP-Regional, Dr. Seni Ananuju, Chair of the Jamaica chapter of the Caribbean College of Family Physicians, Dr. Donald Gordon, President of the Association of General Practitioners, and Dr. Andrea Purai, Chair of the World Family Doctor Day Planning Committee for this year. I say good morning to you and to all our esteemed panelists and participants in the room. Very good to see over 400 persons with us this Sunday morning. I bring greetings on behalf of the Family Medicine Postgraduate Program at the University of the West Indies Mona campus, specifically on behalf of our coordinator, Dr. Kristen Smith, who is not able to be with us this morning. The program is one that has the mission of honing young or maybe not so young doctors to be excellent family doctors. Not only do we place emphasis on increasing knowledge and skills based on evidence-based practice, but also equally important, we look at honing the softer skills of empathy, compassion, and certainly ethical practice in all of our graduates. Working with CCFP-J and AGPJ since 2015, it has been our distinct pleasure to add our voice to the important recognition of World Family Doctors Day. Over the years, there have been three pillars of our celebration. One, the recognition of family doctors of excellence. Two, some outreach activity. And three, our conference. Our recognition of family doctors started from back when we started in 2015, and in 2016, we actually had an awards banquet where many of our excellent family doctors were recognized. Persons like Dr. Winston Davidson, who has been a founding member of the CCFP-Regional and Jamaica chapter, the AGPJ, and who was the first coordinator of the family medicine program here at Mona, certainly a pioneer family doctor. And over the years, we have recognized family doctors of excellence in our annual Gina supplement. And if you read this year's supplement, you will see that Dr. Brown Morgan gave us a review of that. And the doctors of excellence that we are recognizing this year are our own Dr. Seni Onanuju and Dr. Eileen Lopez Gordon. Our second pillar is that of outreach. In our first year, we held a health fair at the Halfway Tree Park, where many of our collaborators, people like NHF, Heart Foundation, and many others came and gave service to the public. In subsequent years, we have done outreach to places like homes for the elderly, homes for children's homes. And this year, our outreach program is the Beatitudes home that caters to boys and young men who have physical and intellectual disabilities. And we would ask you, in lieu of any registration fee for this conference, that you go back to the flyer and see the information on the banking information, and ask you to make a generous contribution towards the Beatitude Home. And the third pillar, of course, is our annual conference. Over the years, we have had many eminent speakers speak on a range of topics and have really always given us a lot of food for thought and have increased our knowledge base. And I'm sure that today will be no exception. So it is with great anticipation that I look forward to today's presentations, and that I wish you all a very good day with us. And once again, greetings from us at the Family Medicine Postgraduate Program at Mona. Thank you very much.
Thanks very much, Dr. Stanagosen. Now we'll hear from Dr. Onanuju.
Sophia. A pleasant good morning to all my colleagues, our specially invited guests, family doctors, frontline healthcare workers, members of the Nursing Association of Jamaica and the Fraternity of the Nursing Group, the Caribbean College of Family Physicians, both locally and regionally, Administrator Lynn Thompson Hyatt, our hosts and IT support personnel, Mr. Samuel Heron, friends, ladies and gentlemen, a deep, heartfelt welcome to you all. The theme of World Family Doctor Day internationally this year is Family Doctors, the Heart of Healthcare. This is very significant as it underscores the vital role that the family physician plays in a multidisciplinary healthcare system and their invaluable inputs in the managing and management and the link that they have between the public and the private sector, and also their input in individual management of patients. This morning marks the 10th year of the World Family Doctor Day celebration in Jamaica. This year's celebration is unusual in the sense that this time around, we celebrate this momentous occasion of World Family Doctor Day just 2 weeks prior to the triennium, which will involve other territories in the region. I am sure it will not simply be a historic artifact, but will mark many more collaborations between local and regional chapters. Indeed, together we are stronger. This year's theme for the conference is Ethics in Primary Care, which is intended to highlight some of the ethical challenges that we are confronted with on a daily basis, both in private practice and as well as public and government service. Alongside the clinical aspects of medicine, ethics continue to play a significant role in the decision-making process in the practice of medicine, as it guides the doctor to be fair and just in dispensing healthcare to patients and their families. Non-communicable diseases are very common, and every family physicians or general practitioners would have been confronted with them at times, at one time or the other. At times, they may present ethical dilemmas for the physicians who now has to be guided by ethical principles to resolve these dilemmas. End-of-life issues are inescapable, as we all will be confronted with them either in the capacity of a physician, relative, or caregiver, or at the patient, or even at the patient, which we ourselves gradually will one day become. While COVID restrictions have been eased or completely removed in some jurisdictions, the threat of new and more aggressive strains continues to loom us with much uncertainty as to what the future now holds. Over time, the lines between geographical boundaries have become increasingly less, and we no doubt will have to maintain our vigilance, not only for mere aggressive strains, but also for new and emerging health threats, whether from environmental or zoonotic sources. As the digital revolution continues to evolve around us, and we as family doctors evolve accordingly, there is a realization that new ethical changes face us. The right to use, own, and distribute information, the use of artificial intelligence in decision-making process are just a few things that are worthy of ethical consideration. Gender has always been a hot topic for this discussion, and more And now as the world evolves, the lines between what is acceptable male and female behavior become less clear. How do we address these challenges while not projecting our own bias and belief system in order to avoid our misjudgment? These ethical dilemmas represent just a few of the challenges that continues or that confronts us daily. Despite unavoidable discomfort, we cannot shy away from them. And so today, we will attempt to confront them. As such, we have a line of presenters, all very qualified and experienced in their respective fields to address the various aspects of ethics in primary healthcare this morning. Professors John Peter Figueroa, Winston Davidson, and Helen Trotman-Edwards, and doctors Alverston Bailey, Dingle Spence, and Karen Carpenter. We also have a lineup of panelists drawn from among the ranks of the Medical Association of Jamaica, the Caribbean College of Family Physicians, and the Association of General Practitioners of Jamaica. Doctors Brian James, Donald Gordon, Pauline Williams Green, Kean Bookall, and William Brown. We welcome you all to this morning's webinar, and we are sure that at its end, we would all have learned a lot. I'd also like to take this opportunity to commend the hardworking members of the World Family Doctor Day Committee for their unwavering support and commitment to the pursuit of knowledge acquisition, which embodies some of the core principles that the different entities have stood for since their inception. May I also seize this opportunity to say a humble thank you to the World Family Doctor Day Planning Committee. It is a great honor to be recognized by one's colleagues. So on behalf of Dr. Lopez, Helen Gordon, and myself, Dr. Seni Ononuju, I take great pleasure in saying a big thank you for selecting Helen Lopez Gordon and myself as the Doctor of Excellence for 2023. We are deeply grateful that we were considered for such an award. I also wish to say thank you to the World Family Doctor Day Committee for reaching out to the mentally and physically challenged wards of the Beatitude Home. We are also very deeply grateful, and we thank you, because many people would have said, after all, they didn't have need to be talked to because they cannot speak, they cannot do this. But although they are not speaking as we speak, they have their emotions, and it is a good thing that somebody reach out to them. And so for this, we say thank you again. And actually, I am saying whatever I'm saying on this ground on behalf of the Caribbean College of Family Physicians, all of us. We are grateful for all you've done this year, and a lot of work has been done by the committee. There are things that I see there and see, and I don't want to single out anybody, but I thank everybody, even those who you didn't see their names. I'm grateful. So please sit back and enjoy the presentations. And thank you, and God bless.
Thank you very much, Dr. Onanuju. I'm Dr. Brickian. I'm just going to introduce our first speaker, Professor Alverston Bailey. Just a little bit of quick background about him. He's a graduate of UWI, and he has over 40 years experience in public health and occupational safety. Currently, he also has been a lecturer at the Caribbean School of Medical Sciences in Jamaica since 2016, and he currently practices in Trelawney as an occupational health and safety consultant, as well as a family physician. And he has been an author, he is an author, and he has done a lot of work related to diabetes. He's been co-chair of the University Diabetes Outreach Program, UDOP, and has worked closely with the Diabetes Association. So it's quite appropriate that he'll be talking to us today about ethical demands in treating non-communicable diseases and managing ethical violations in primary care. Welcome, Professor Bailey. Thank you for being here. We look forward to hearing from you.
Okay. Thank you very much for your kind introduction. First, let me congratulate the Caribbean College of Family Physicians for putting on such an important conference addressing issues that are at the epicenter of the practice of medicine, which is ethics. My task for you over the next 25 minutes is to just share with you some of my concerns with respect to ethical demands that we face in primary care, especially in addressing non-communicable diseases. And because of my experience, particularly with diabetes, I'm going to zoom in on diabetes as clinical cases which can be replicated in all the NCDs. So I intend to discuss the ethical challenges faced by a physician in managing NCDs using clinical scenarios in case of diabetes mellitus. I'm very pleased, in fact, that I was asked to be the first presenter, because I'm sure over the next few hours, my colleagues will expand on some of the concepts that I'm going to share with you and clarify some of the issues that even I am grappling with. Let me therefore remind you of what is ethics. Ethics is said to be a well-founded standard of right and wrong that prescribe what humans ought to do in terms of rights, obligations, benefit to society, fairness, or specific virtues. Ethical standards also include those that encourage us to be honest, to be compassionate, and to be loyal. Ethical standards include standards relating to rights, such as the right to life, the right to freedom from injury, and the right to privacy. Such standards are adequate standards of ethics because they are supported by consistent and well-founded reasons. So let me remind you, according to Claire Andre and Velasquez in Issues in Ethics, published in 1987, that ethics refers to the study and development of one's ethical standards. Feelings, laws, and social norms can deviate from what is ethical. So, colleagues, it is necessary to constantly examine your standards to ensure that they are reasonable and well-founded. Ethical also means the continuous effort of studying our own moral beliefs and our moral conduct, and striving to ensure that we and institutions we help to shape live up to standards that are reasonable and solidly based. I particularly like this flow chart because it asks you a question. Are your ethical theories based on conduct or character? What sort of action should we perform? What sort of people should we be? The next slide emphasizes this concept. When we make decisions, do we resort to consequentialism, i.e., we are Mill's utilitarian, which states that an action is right if it promotes the best consequences? Or are you Kantian and would argue that an action is right if it is in accordance with a moral rule or principle? Or are you Aristotelian and argue that an action is right if it is what a virtuous agent would do in the circumstances? So, what makes an action good? Is it due to consequentialism or non-consequentialism? Do you argue that you'll act because of you're ensuring the greatest good for the greatest number of people? Or would you argue that goodness consists of virtues that lead to human happiness? Are you spiritually driven and rely exclusively on spiritual dictates? Or are you a deontologist and argue that you will act according to rules and regulations? So in summary, if you're a consequentialist, you'll argue that the means justify the ends. If you're a non-consequentialist, you'll argue that it's more about the journey than where you end up. Think on these things. Just to remind you quickly, therefore, that the fundamental principle of ethics includes autonomy, beneficence, non-malfeasance, and justice. Autonomy. Robert M. Taylor, in his book, Ethical Concepts in Medicine, reminds us that a patient's right to the refusal of care is founded upon one of the basic clinical principles of medicine, autonomy. The principle states that every person has the right to make informed decisions about their health care, and that healthcare professionals should not impose their own beliefs or decisions upon their patients. Beneficence, according to Taylor, requires that actions taken by healthcare professionals be for the benefit of the patient. Non-malfeasance. He further states that non-malfeasance is the principle that embodies do no harm. This requires healthcare providers to take steps to ensure their patients and society at large are not harmed by their actions. Justice. Taylor finally implores us to remember that justice requires that the benefits and risks associated with healthcare should be distributed equally amongst the population without bias. But we need to mention an important concept called capacity. And when I discuss the clinical scenarios, it will bring home clearly why this is important. Capacity is defined by Raphael Leo as a person's ability to process information and make an informed decision about their care in a way, and I want to repeat this, in a way that is in line with their beliefs, their values, and their preferences. Capacity, therefore, is a crucial factor to consider when a patient is refusing care, as it is used to differentiate between someone whose decision-making may be impaired and someone who's exercising the right to autonomy. Alec Buchanan in 2004 argues that capacity is the definition which the medical community should use to assist with healthcare situations and choices. First, a patient needs to express understanding about their medical condition. Secondly, the patient needs to express appreciation. Appreciation is defined as when a patient is able to apply the understanding of their situation to their own life. Please note, colleagues, that if a patient is able to explain the situation but does not understand how it applies to their situation, they lack appreciation. Finally, reasoning. Reasoning is the patient's ability to infer the consequences of their decision and to express an explanation as to why they would rather refuse care. Finally, let's look at competence. Competence, according to Buchanan, is the legal assessment of a patient's ability to make medical decisions that can only be decided by the judiciary system. It refers to ability to enter a contract or prepare a will, but for a person to be said to be incompetent, we as physicians must ensure that there's clear and convincing evidence to make that decision. So let me invite you now to look at some ethical dilemmas that we all have to cope with in the management of NCDs. And I'm going to zoom in on diabetes to emphasize these points. Driving and glucose monitoring. This is a case in which a 43-year-old male truck driver with type 2 diabetes who was converted to insulin 18 months ago is being monitored at the clinic. At a routine review last week, his doctor advised the driver of the rules governing driving, and this is the British rules about driving, blood monitoring, and hypoglycemia. He mentioned also in passing that he had 2 blood glucose meters and intended to use the second one only because the first had measured a hypoglycemic episode. When he was inquired about this, he insisted that he intended to show only the screen measurements on the second meter to the DVLA consultants at the next month's annual review. The patient showed a good understanding of hypoglycemic symptoms and signs and insisted that he had never driven outside of the DVLA guideline. But, and I want you to pay careful attention to what happened here, he advised the doctor in leaving that he knew his rights, and this had been a confidential discussion between him and his doctor. Now, colleagues, this is a disconcerting situation, not only because of the emotional context of this man's livelihood potentially being at risk, but also because of the risk to the lives of other road users. Healthcare professionals like ourselves are often made aware of information, which now includes you in assuming overall responsibility should harm come to others. In some sense, the situation is clear-cut, and we could resort to deontological principle and insist that we will follow the rules. Even though the patient states that he has not broken any rules, we have to take his word for this, that he knows what to do. He does not intend to openly declare all his glucose readings at his annual driving exam. But if he does not declare his true results at the meeting, he is breaking the law. So, if you adopt a utilitarian approach, it could help you to decide what to do. In other words, you're going to use the ethical principle, which is the greatest good for the greatest number. So, you might override the rights of one person to protect the lives of many others. The patient has to be made to understand that no action is inadequate and that he's breaking the law if he does not act, and that he cannot ask a health professional to turn a blind eye. If the individual goes ahead and decides not to declare all glucose readings, the health professional might have to break the duty of confidentiality and report the patient to the authorities. This scenario look at the principles of autonomy, the rights of an individual, the ontology, the study of duty, and utilitarianism, the greatest good for the greatest number. Let us look at another scenario, covert medicine. Mr. M, and I particularly want you to focus on this one, colleague. This one is very interesting. Mr. M is a 79-year-old man with type 2 diabetes and dementia. His diabetes was well controlled in the past, as his wife used to ensure he took his metformin and sitagliptin regularly. She was his main carer, but sadly developed metastatic breast cancer and died 12 months ago. Since her death, his self-neglected culminated in several hospital admissions with confusion and hyperglycemia secondary to poor concordance. After the third admission in 6 months, he has been cared for in a local nursing home, but still regularly refuses to take his prescribed medication and regularly tries to go home. But he has a niece and no other close relatives. She is asking about him being given his medication disguised in his food so that he remains well and hopefully avoids another admission. This involves a range of complex ethical decision making. I don't know if many of you know this, but in the UK, in the past, infirm nursing home residents, and I'd love my colleague who's involved in palliative care to comment on this afterwards during the question and answer. Infirm nursing home patients, especially those with behavioral issues, were given a covert or even overt unwarranted medication described as a chemical kush. Do we do that in Jamaica? I invite your comment. But just to remind you that the chemical kush was deemed inappropriate in the United Kingdom in 2008. And it took published evidence of the increased cerebrovascular and fall-related risk in combination with far improved recognition of the rights of cognitively impaired people to change attitudes. So, this best interest request can create anxiety in the mind of many healthcare professionals. In this circumstance, the capacity and understanding of Mr. M needs to be clarified. His current physical and mental well-being and the views of his needs need to be explored. Let me remind you that best interests have been defined in the House of Lords as actions taken to preserve life, health, and well-being, including the well-being of relatives. And decisions on behalf of a third party should be justifiable, proportionate, and least restrictive of the available options. Therefore, if he lacks capacity to make these decisions, we need to ask, what are his probable pre-morbid wish, and does his next of kin have a lasting power of attorney for medical matters? And do we know if the good concordance with his wife when she was alive was because of their long-term relationship or his capacity at the time? In this situation, the deontological argument is easier to accept, thanks to the mental capacity act deprivation of liberty safeguards. Do we have this in Jamaica? If he is effectively being kept in a nursing home against his will, and as he lacks capacity, the nursing home must request a DOLS assessment. Do we have any such safeguard in the Caribbean? I invite your comment. The request and any decision in this instance is controversial, and therefore, as with many ethical issues, enough information needs to be gathered, and several stakeholders need to be involved in the decision-making process. Therefore, a best interest decision, given the current facts, an ethical principle of consequentialism will probably support the covert use of medication, but this has been made by a team. This issue, therefore, is about protecting the rights of an individual. Let me remind you that if Mr. G were capable of giving informed consent or dissent, then the debate would have to stop here. And then we'd have to resort to what is called virtuous ethics, which I'll discuss shortly. Therefore, with thoughtful consideration, it is my opinion that covert medication has a limited but important and appropriate role in this instance, because if no medication were given at all, this could be regarded as neglect of care. Let's look at informed consent, which we see very often in our practice. Miss G is a 93-year-old spinster with type 2 diabetes, peripheral artery disease, varicose eczema, and chronic mixed etiology severe leg ulceration. She now needs daily dressing as the leakage seeps through within 24 hours. It is suspected that she might be interfering with the dressings at home. Over the past 3 years, she has seen various specialists, including a diabetologist, dermatologist, vascular surgeon, tissue viability nurse, and care for the elderly physician. The consensus recommendation was that a below-knee amputation is now the only viable treatment option. She adamantly refuses and has refused to see another specialist. The district nursing team has declined to see her, as she is clearly not housebound. However, the practice nursing team is struggling to see her as frequently as would be ideal. It can take up to 90 minutes of healthcare assistance or practice nurse time to address her needs. This is a genuine ethical dilemma for Ms. G and the primary care team, as well as other societal issues. I want you to pause to look at bullet number 2. I want you to pause because this says that if she has fully understood, fully retained, and weighed up the information and communicated her decision, it's called the URCC test, then she has the right to make a decision with which her healthcare team disagrees. If she has understood, retained, and weighed up the information and communicated her decision, then she has the right to make a decision with which her healthcare team disagrees. By talking through the implications of any decision or recommendation, it might help. It might highlight to Ms. G and her healthcare team the difficulties and underline the fact that there is no single correct best answer. Therefore, in this particular case, a multidisciplinary team is required to debate the issue. In this scenario, we look at utilitarianism, consequentialism, autonomy, deontology, and social justice. I'm going to end my presentation by looking at 2 other interesting ethical dilemmas. This one is called the rights unborn. I want you to remain focused on this, because this is an extremely important ethical dilemma. Mistress X is a 31-year-old overweight, pregnant mother of 2 young children. She had gestational diabetes in her second pregnancy, which culminated in a very difficult delivery, secondary to having a large for-date infant. She underwent an emergency cesarean section because of fetal distress, and the baby had significant problems with neonatal hyperglycemia. She has developed gestational diabetes in her current pregnancy, but has gained a lot of weight and is poorly concordant with taking her insulin. The diabetes specialist is concerned, but she's ignoring all his concern. The other day, her husband attended with the children for the flu vaccination, and he's concerned that something similar to last time will happen to their unborn baby. This situation, colleagues, clearly raises multiple worrying issues. Many individuals from primary and secondary care are now involved, and they all have their autonomous rights and deontological responsibilities. I know my colleague, Dr. Derek, will be looking critical at this one, and I'm sure you would agree with me that even though the two parents perceive the risk differently, and I'd love for someone on the panel when we discuss this later to offer an alternative point of view. The ethicists argue that is the mother who, providing she demonstrates capacity, has the ultimate right to decide. Therefore, we need to determine what is her level of understanding, what are her perceived barriers to recognizing the healthcare team's drive for good glycemic and weight control. Does she really appreciate the wider potential ramifications of the possible harm to herself and her unborn infant? Now, by definition, to make a truly autonomous decision, an individual, the doctor, or the patient need to have enough balanced information about the risk in order to make an informed choice, whether consent or dissent. The most challenging moral dilemma, colleagues, in this situation concerns the right, or rather the lack of rights, of the unborn child. Does the unborn child have a right? Now, we could argue the case of intentional harm. If intentional harm were construed, theoretically, one should report the mother to the local authority, accusing her of putting her unborn child at risk. This is a thin judicial line. Consequentialism arguments could be carefully framed to her without being accusatory or intimidating. At this stage in her pregnancy, it is important, colleagues, that she regards the healthcare team as welcome partners in her pregnancy and delivery. It has been brought to my attention that in the UK, unborn children have no legal recognition. This is debatable. I invite my learned colleagues among you to invite me of what is the Jamaican situation. Therefore, a primary care physician is to keep her engaged and try and encourage her to explore, try and determine what her values are, and see if you can implement behavior change. And therefore, in this scenario, what we are emphasizing, care-based ethical arguments to remain compassionate, empathic, and caring. I'm going to end my presentation by looking at an issue which I have to grapple with all the time. And for those of you who are not familiar with the concept, it is called therapeutic or clinical inertia. Therapeutic or clinical inertia is a failure to intensify the treatment of any patient, whether it be diabetic, hypertensive, hypercholesterolemic, asthma, obesity, and so on. Failure to intensify the treatment of a patient, in this case a diabetic patient, who is not at his or her HbA1c goal according to standard guidelines. Let me remind you that in 2016, the American Association of Clinical Endocrinologists recommended intensification of antidiabetic therapy every 3 months, culminating in initiation of insulin on failure to achieve A1C target. However, we as family physicians know that intensification of therapy is associated with health risks to patients which cannot be always predicted. The ethical dilemma, according to Kunti and his team, encountered by clinicians when considering intensification of therapy in type 2 diabetes in attempting to balance their desire to achieve glycemic targets promptly with the need for averting risk to the patient from overtreatment, non-malfeasance, has been extensively studied in the developed world. So clinicians, when treating diabetic patients with suboptimal glycemic control, while also lacking social support and financial protection, may experience a dilemma in strictly advocating insulin therapy, considering the difficulty in its acquisition and safety. The ethical challenge, therefore, of balancing desire for beneficence, improved glycemic control, while avoiding harm, inadequate therapy, is a major one. Patient-directed clinical inertia, therefore, involves the ethical challenge of respecting the patient autonomy while upholding the clinician's duty towards beneficence. We also have a dilemma, especially in resource-poor setting, with relation to patient diet and lifestyle management. The challenge of selecting a healthy, culturally appropriate and affordable dietary plan for a poor, semi-literate and culturally diverse population can be daunting. Similarly, recommendations for physical exercise can remain unmet. So, how do we overcome clinical inertia? I invite you to make that decision. You, my colleagues, have to decide what makes an action good. Will you, for your decision, look at all the ethical theories and make a decision based on utilitarianism, Aristotelianism, a spiritual ethos, or deontology? Let me remind you that in Mill's utilitarianism, an action is right if it promotes the best circumstance. Kantian argues that an action is right if it is in accordance with a moral or rule principle. Aristotle reminds us that an action is right if it is what a virtuous agent would do in the circumstance. My colleagues, it was a pleasure sharing my thoughts with you. My choice is, in most instances, to opt for care-based ethics, which is a subset of virtue ethics and is, in a sense, summarizes what many would regard as the essential requirements of what makes an ideal healthcare practitioner. Let me therefore advise you that when you're treating non-communicable diseases, to be compassionate, to be confident, to be conscientious, and to relate to your patient with sympathetic understanding and responsibility. I thank you.
Thanks very much, Dr. Bailey. We will go to a brief sponsor's presentation now for about 10 minutes.
Are you feeling tired and weak? Not eating properly? Recovering from an illness? Take Vitamix, the complete sugar-free multivitamin mineral syrup with over 15 essential vitamins and minerals the body requires daily. Take Vitamix to boost your immune system, enhance your appetite, and boost performance with added antioxidant support. Kids love the taste, adults love the benefits. Vitamix, for overall good health in one spoonful. Vitamix, the complete supplement for the whole family.
Borototal Neem Cream, an Ayurvedic antiseptic cream that heals, soothes, moisturizes, making it the perfect companion, the power-packed herbal alternative for wound healing and skin infections. The ingredients in Borototal are neem, aloe vera, sesame seed oil, asoka or ashaka, licorice, and zinc. Borototal is effective and useful when treating nappy rash, dry cracked nipples, blisters and burns, acne, insect bites, and much more. Stay flawless without bleaching with H2K Naturella. H2K Emerge Pill, levonorgestrel 0.75 mg. When you have failed birth control or unprotected sex, speak to your pharmacist within 72 hours and Emerge, the morning after pill. Those were some of our over-the-counter products. Now for a reminder of some of our prescription medication. H2K azithromycin 500 mg. Azithromycin is used to treat chest infections such as pneumonia, infections of the nose and throat such as sinus infections, skin infections, Lyme disease, and some sexually transmitted infections. Azithromycin, the 3-day success. Did you know we also offer SCASI 200 oral azithromycin suspension? It has a menthol minty flavor, enhancing compliance in children and the elderly. H2K co-amoxiclav 625 mg and 1000 mg. Co-amoxiclav is given to treat bacterial infections. It is prescribed for sinus infections, urinary tract infections, chlamydia, syphilis, skin infections, joint infections, and some dental infections. It is also given before some surgical operations to prevent an infection from developing. H2K co-amoxiclav stop bacterial infections right in its tracks. H2K fluconazole 150 mg. The single-dose success in vaginal candidiasis, acute, recurrent, and prophylaxis to reduce the incidence of recurrent vaginal candidiasis. Also used to treat Candida balanitis. H2K protride 5, finasteride 5 mg for the treatment of symptomatic benign prostatic hyperplasia and also male pattern baldness. H2K tamsulosin hydrochloride modified release 400 microgram, the prostate selective alpha blocker to relieve BPH quickly, safely, and with exceptional tolerability in long-term therapy. H2K acyclovir 5% cream, fast-acting antiviral medication for cold sores. H2K ibuprofen 400 mg and 600 mg. Reduces swelling, relieves pain in dysmenorrhea and pelvic inflammation. When ED tears you down, get back up with Tadalafil 20 mg for the treatment of erectile dysfunction and symptoms of an enlarged prostate. Tada lasts for 36 hours, so versatile when you need it most. Go from 0 to 100 with Migra 100 sildenafil 100 mg tablets for the treatment of erectile dysfunction and pulmonary arterial hypertension. Migra takes effect 30 to 60 minutes before sex and lasts for 24 hours. Thank you for listening to some of what we offer at Health 2000 Canada, otherwise known as H2K. We proudly serve the Caribbean since 1999. Doctors, please support us by writing H2K before the drug name on your prescriptions. All our products are available in pharmacies island-wide. Please ask for them. Thank you and have a wonderful webinar.
And now we hand over to, I believe, Abbott, Mr. Russell. Paul, over to you.
My video. Start the video. All right, thank you for the opportunity. Let me just share my screen. Are you seeing my screen?
Yes, we are.
Your logo, the Abbott logo.
Okay, yes. All right. Good morning. My name is Paul Russell from Abbott Nutrition, and I'd like to thank the World Family Dr. Day Committee for the opportunity to present on some of my products. So let us first look at Errol. He's a bit overweight. He's made poor nutritional choices and has one or more chronic conditions. Like Errol, we know many patients have hypertension, may have high cholesterol, and are obese. They sometimes struggle with nutrition, whether it's overeating, they consume high-calorie snacks or drinks, and have inconsistent nutrient intake. For Errol, he would need to replace his nutritionally poor food choice with a product like Ensure Max Protein. Now, Ensure Max Protein has 30 grams of high quality protein. It has low fat, it has 1 gram of sugar, and it's only 150 calories in 10 fluid ounces. It has 25 vitamins and minerals and is an excellent source of antioxidants, vitamin C, E, and selenium. So let's also now look on Miss Joyce. She's frail, she's recovering from a setback, and she's not getting enough nutrition. Like Miss Joyce, persons recovering from a health setback or malnutrition can face daily challenges, problems getting up and moving around, unintentional weight loss, decreased muscle strength, and persons like Miss Joyce need additional calories, they need proteins and nutrients to help improve their nutritional status. 40% of adults over age 50 consume less than the recommended daily allowance of protein from food alone, and they lose muscle mass at a rate of 8% per decade. At ages 70, the rate of decline is 15%. So Ms. Joyce would need to add Ensure Complete to increase protein and her calorie intake. Ensure Complete has 30 grams of high quality protein for sustained delivery of protein to muscle. It's calorically dense with 350 calories, and it's an excellent source of omega-3 for heart health. It's an excellent source, or provides an excellent source of antioxidants, vitamin C, E, and selenium for immune health. And it has 4 grams of fiber to assist with digestion. For your persons living with diabetes, life doesn't have to stop. Over 50% of persons with diabetes reported consuming less than the RDA of protein. And this situation can be associated with overall poor diets, consuming more carbohydrates than necessary, and leading to more physical limitations. By incorporating a high protein diet, persons living with diabetes can maintain muscle, can support weight management, can manage blood glucose, and manage hunger. Glucerna shakes help patients support their nutritional goals, and Abbott offers 3 presentations for the local market. We have Glucerna Original, Glucerna Hunger Smart, and Glucerna Snack Shake. I have included my business card with my cell number, 876-489-6093, and my email address, which is paul.russell, spelled with 1 L, @abbott.com. I thank you for the opportunity to share with you, and I'll be putting my details and information in the chat should you want to contact me with any concerns, any issues, any questions that you may have. Thanks for the opportunity.
Thanks so much to our sponsors. Back to Dr. Brikia.
Hi, so I'd like to introduce Dr. Dingle Spence, who is our next presenter, well known to us. She's very qualified in clinical oncology, palliative medicine. She's a SMO at Hope Institute Hospital, as we know, and an associate lecturer at the University of the West Indies, Mono. She's also director of Jamaica Cancer Care and Research Institute. And interestingly, she has a special interest in providing access to oncology and palliative care to Jamaican and Caribbean providers, and also has research interest in use of plant-based medicines such as cannabinoids and psychedelics for holistic symptom relief for people who are having palliative care needs. Welcome, Dr. Spence, Dr. Dingle Spence, and she'll be talking to us about ethical challenges in palliative care in general practice. Thanks very much for being here.
Thank you. Good morning, everybody. Let me just get my screen set up there. Okay, hopefully you can both hear me and see my screen.
Perfect.
Great. And I will just update you on that introduction that I actually have now retired as SMO of the Hope Institute on the 31st of March this year. So I am no longer working in the public sector in Jamaica, but still work in the private sector. So yeah, so that's a change. So I want to talk to you about ethical challenges in palliative care in general practice. Let's see if we can move this along. All right, so as usual, we're going to do some definitions and introduction, and I have to say thanks to Prof. Bailey, who has already covered some of what I would have touched on, so we can go quickly over that. I really want to dive into the importance of communication when we are applying ethical principles and how we use communication to help discuss what we call goals of care. And I'm going to do this around some case-based examples, and I have no disclosures to make today. So as usual, we want a definition, and I know many of you have heard me speak before, so this is, and most of this talk, by the way, should be revision rather than new information. So palliative care, and this is a definition by the International Association of Hospice and Palliative Medicine. I was very privileged to be on the board until the end of last year. And this was a consensus definition that we, it's a little bit different than the WHO one, which many people are familiar with. So palliative care being the active, holistic care of individuals across all ages with serious health-related suffering due to severe illness, and obviously especially for those near the end of life. And in relieving suffering, we hope to be able to improve your quality of life. And that's a bit of a shift in the way the definition, the WHO talks about palliative care being about quality of life, whereas this one talks about relieving suffering first, and therefore in so doing, we hope we improve your quality of life. And obviously not just for the patients, but for their families and their caregivers, because as we know, everybody is suffering when folks are ill. And just to also remind you that palliative care was designated now 21 years ago as a human right, both by the WHO and by the what we call ECOSOC. And also in 2014, the World Health Assembly, there was unanimous vote that providing palliative care throughout the life course is an ethical responsibility of health systems, not a, oh, maybe we should think about it, oh, perhaps that's something we should take on. It was designated an ethical responsibility of health systems to be able to provide palliative care for their population. And without palliative care, both in cancer and for other serious chronic illnesses, definitely care is not as medically effective as it could be, certainly not as compassionate as it should be, and does not fulfill people's human right to palliative care. So this talk is a call, obviously, to think about what does it mean to be ethically responsible in providing palliative care for our patients. And obviously this is based around community focus rather than hospital focused palliative care. So again, just a reminder that palliative care is a response to the suffering that we can't fix or cure. So this is what we all got trained in, traditional or conventional medicine that is very focused on prevention, fixing and curing. Although, as I'm sure you will recognize, can we cure diabetes? Can we cure hypertension? Can we cure heart disease? We manage it, but we don't cure it. And so palliative care is really about the relieving, which is a lot of what we do, comforting, which I would say we don't do enough of, and supporting people. And being able to do all of that is something that we should be thinking of as healthcare professionals. So in the beginning, we may not need much palliative care, but as the disease progresses and time goes on, it may be that relief, comfort, and support is actually more where the focus should be rather than the attempts to fix or cure any particular illness. And so we're talking about what I've really already said, provide relief from suffering, maximizing quality of life in so doing. And because it's holistic, we're talking not just about the physical body, but we're talking about the emotional, social, and spiritual lives of our patients. And of course, as a single healthcare professional, we cannot do all of those things ourselves necessarily, but we do need to recognize that palliative care is a team approach. And certainly, you know, we call on many different facets of our medical and allied health professionals to support our patients in the palliative care arena. So when should it be provided? And people tend to think, oh, palliative care is just end of life care and we're not going to refer until the person is in the last week of life. Nothing could be further from the truth. We actually need palliative care right from the beginning, especially if somebody has complex advanced illness. As you know, I'm an oncologist, so you know that's what I treat, but that doesn't mean that that little old lady with a 93-year-old woman with her leg ulcer, she sure needs palliative care. So we'll probably bring her into the discussion. So, you know, you have screening, hopefully prevent things from happening, but then you have a diagnosis, the illness progresses, curative care is the main focus at the beginning, but we need to recognize that palliative care can be introduced early, should be introduced early. And in fact, there's a growing body of literature that suggests that early introduction of palliative care actually reduce healthcare costs. So this should be like music to our ears, music to the government's ears. And I'll talk a little bit more about a government initiative that's happening in a minute. And so just again to say palliative care includes end-of-life care, but is not only end-of-life care, as you can see from this diagram. And so, you know, what we get taught in med school, and I went to the same med school as many of us on the call, UWI, a long time ago. And what we get taught is disease-focused medicine. We don't really get taught, although we went into med school thinking we wanted to look after people, and we come out of med school being very disease-focused, and we forget, although I'm hopeful that our primary care colleagues are more focused on people, but certainly in general, we tend to become very disease focused and we're not person centered as much as we should be. And so what we're trying to do is to bring back the people centered accompanying as we look after our patients. And of course, the family physician, the general practitioner is perfectly placed to be that person focused practitioner in our patients' journeys. And so in fact, we should all have some basic training in palliative care. Palliative care is not a specialist discipline, although you may need specialists, but all of us generalists should have some basic training in palliative care. And I'm hopeful that we'll be able to provide that at a university diploma level beginning in 2024. So here we are. This is really what it should look like. And this is not my triangle. This is, although it says WHO, yes, WHO should provide it, but it's also a WHO triangle. So really, this is where we should be dwelling. We should be community focused, primary care focused, and all of us, in fact, in medicine and nursing and professions allied to medicine should have some basic understanding of what we mean by palliative care and the palliative care approach, and that palliative care is really a public sector and a public facing specialty. And so we ought to be able to be delivering palliative care at home, in our community health centers, in our private family doctor offices. That's where palliative care should dwell. Unfortunately, in Jamaica, everybody's used to this model because, again, unfortunately, palliative care has really only been delivered at this level from the Hope Institute Hospital and only for people with cancer, when in fact, it should be the upside down, that this is really where we should have started. I mean, at least we have palliative care, right? But really, this is where we should be. We should have some slightly more specialized and focused folks in our type B and C hospitals. And that specialist palliative care is a unique offering, in fact, and it's not what you see worldwide. This is where the focus is worldwide. But in Jamaica, because this is what we have seen, we tend to think that palliative care dwells up here, when in fact it really doesn't, and it should be a much broader based triangle. So I'm hoping that people will rise to that call here today. And yes, I'm not saying we shouldn't have specialist palliative care to support everybody else, but that should not be the only place that it dwells. And I'm excited to say, and I'm sure most of you know, because you're in primary healthcare, or most folks on the call, that the Ministry of Health and Wellness is undertaking a primary healthcare reform for Jamaica. And there's many services to be revamped, but there's a new service that we're wanting to introduce, and that is community-based palliative care. So in order to introduce this into the community, we need training. And I'm hoping that, to continue to work with the Ministry of Health in how we structure that training for healthcare professionals in Jamaica and also in the region. So I think that's a very exciting initiative. And then I just want to draw your attention to this very, very important document and report. And I'm very grateful to say I was an advisor on this report. It was published in 2018, the Lancet Commission on Global Access to Pain Relief and Palliative Care. And what we did is that we came up with what we call an essential package of palliative care that should be affordable, whether you live in Haiti, whether you live in Lesotho, whether you live in Jamaica, or whether you live in the United States. It's a very basic package of intervention. So we're talking about safe, effective, inexpensive, off-patent medications. It's a list of about 20 meds that we would all be familiar with. Some very basic equipment that would include like adult diapers, soft mattress, if possible, UCAS and things like that. Nothing fancy. Basic social supports like access to social work advice, and also spiritual advice if possible. And one of the most important things is that you can't do any of this, again, unless we have trained human resources, which means you and I. So we need some basic training in order to be able to offer a basic essential package of palliative care to our patients. So the usual, I'm not going to go through this, we all know this, and the pillars of medical ethics are exactly the same in palliative care as they are in general medical care. Although some of the ethical principles shine in big red lights in palliative care, and I hope that I can just highlight some of those for you. So I think it's important we say autonomy, but what do we actually mean? So we're talking about our relationship to the patient. Do they understand what's going on? A lot of the time, particularly if you're a cancer patient, people don't understand what's going on. What are they hoping for? Can they make decisions? And here we come back to capacity and competence. What about informed consent? Too many procedures, too many things happen. People don't really understand what they're consenting to. Can they make a plan? Can we engage in a plan of care, and who are the support systems for this patient? Very, very important. And how do we find all this out? Well, we'll get to that in a second. So when we talk about beneficence, instead of just saying, oh, beneficence, what can I really help? Are we fixing what's wrong? Is it possible to fix what's wrong? Am I effectively managing this disease process? Am I appropriately managing my patient's last days? This is a big issue because unfortunately, this isn't often done well. And in managing my patient's last days, am I actually causing harm? Am I going into the home and putting up an IV because the family is freaking out that my relative is not drinking enough? And am I giving 2.5 liters of IV fluids to an 83-year-old woman who is really actively dying? That's actually causing harm. And again, where do I sit in beneficence versus non-maleficence? And I think we say minimize harm. What do we actually mean? And one of the things that is a huge concern to me is that poor communication that happens often in hospitals and also in primary care is a form of maleficence. So when we offer information in an insensitive way, when we continue to support aggressive treatment that's not suitable to the patient's condition, when we withhold or withdraw treatments that may be beneficial, or we continue things that are harmful. And then one of the big problems and concerns is to ensure that what is the goal of care of treating this patient? And are we putting people into situations where there's huge social and financial drain on in their situation when in fact the treatments are inappropriate for their stage of their disease. So all of these things are huge concerns and are very much a focus in palliative care. So of course, I'm sure that there are many ethical challenges in family medicine, and I'm going to just have a look at some of them in some case-based ways. So common ethical dilemmas, the first few are very much hospital-based, and I'm aware of that. Although the artificial nutrition and hydration may come into practice a little bit in the community. So I'm not going to talk about any of the hospital-based ones. It's important to know who the proxy or surrogate decision maker is for your patient. Some of the things that we maybe more see in the community is disagreement between the patient and their family and maybe the medical team or the family doctor. You know, are we still giving statins to somebody who's in the last 2 weeks of life? You know, are we thinking through medications and appropriate medications as people come towards the end of life? We need to be aware and respectful of religious and spiritual preferences at the end of life. And I'm going to also just mention the principle of double effect, which is a very important ethical principle as we go through. So let's talk about Shirley. So Shirley's 68. She was admitted to hospital. You've been looking after her for a while, and she's been having some bad upper abdominal pain and nausea. And eventually, you know, you did an ultrasound and it shows something in the head of the pancreas, and she is admitted to the hospital and she has further tests. She actually doesn't end up having surgery because quite rightly what she has is inoperable cancer spread to her liver. And her daughter Claudette actually hears a couple of the doctors discussing Shirley's case, which is not good already. That's a breach of confidentiality right there. You're talking about a patient in a corridor where you can be overheard. And Claudette says, listen to me, do not tell my mother what her diagnosis is, because, and you know how it is, there's an endless list of issues, because she'll go fret, she'll go die quicker, she can't manage, she's just going to stop living, etc., etc. So anyway, Shirley is not informed of her diagnosis in the hospital because the doctors declined to talk further to her because Claudette begged and pleaded with them. So actually now Shirley is back home. She was sent home with some pain medicine, but very little information about what's going on with her. So now Claudette is bringing her to your outpatient, to your clinic. And she's getting worse. She has more pain. She has, that should be weight loss, not weight loss. And she does not understand what is going on, and nobody will talk to her, and she's quite distressed. And Claudette is still being very protective of her mom. So let's just segue briefly into what's going on here. So communication in palliative care, and I know those of you have heard me talk about this before. Sorry to be repetitive, but it's the same message every time. Listen, 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 listen. We need to start with listening. We ask a question and we listen. Communication in palliative care is like our principal tool. When you're a surgeon, you're great with a scalpel. When you're a diabetologist, you know everything about glycemic control. When you're in palliative care, and I should actually say in medical practice, we need to be good communicators. And why? Well, if we don't communicate in an effective way, we will not have the trust of our patient. We will have people who, like Shirley, doesn't understand what's going on and is in a place of major uncertainty. She's also in the midst of a conspiracy of silence, and which is not helping her at all. And if people don't understand what's wrong with them, we can't help them determine what their goals of care are, given that they're competent and able to make decisions. So communication is the fundamental platform on which we need to move forward, to build on, to be able to do effective palliative care, and I would say medical practice in general. So a couple of quotes here. Marjorie saying, the way that the doctor spoke to me caused me more pain than I experienced from the disease itself. I used to hear this pretty much every day. Boy, doctor, the way them talk to me, me just feel terrible. Or them don't talk to me at all. And here he is saying a portion of the suffering that people experience resulted from the ways that doctors communicated with them or didn't communicate with them. And I think it's really important that we understand that, you know, we talk about doing no harm, but we don't realize that the poor communication that happens between doctor and patient and nurse and patient, etc., is actually causing extreme harm, and it can just be poor communication or lack thereof. So I think in a way that's one of the most important ethical principles that is constantly being breached because we don't understand the effects of poor or lack of decent and appropriate communication. So an essential skill, and we have to think about all of these things. Listening is the fundamental place where we start, and there's all different types of communication. Obviously, breaking bad news is something we have to do a lot in the cancer space. It's a different way of different things you need to be saying to people who are coming to the end of life. We need to communicate with our colleagues. We need definitely to have mutual respect all around. You know, if we don't listen to people and ask them questions, we don't know what they want. Therefore, it's impossible for us to support them in their decision making. So I can't go into you know, the facets of breaking bad news today, but the simple thing is ask what's going on with you. Do you understand? Where are you at? What have you been told? And listen to what the person says to you, because if you don't ask, you don't know where to start. So you need to understand where your patient is at first and not interrupt them. Doctors interrupt their patients within 10 to 15 seconds of the patient starting to talk. Once you understand what they understand, then you can give some news or some information, having checked that they want it in the first place. And then you can go back and ask again, did you understand? What else would you like to do? Can we make a plan now? So if all you remember is ask, tell, ask, and you put that into practice, you'll be going a far way. And I'll just point you to this bottom, which is a quote, which is from a palliative care physician in Canada, who says that effective communication is the foundation on which rests the alleviation of a patient's suffering. Okay, and then if there's poor communication, you know, we can be providing life-prolonging care when it may be futile, more suffering, psychosocial morbidity for everybody. Perhaps if communication is poor, people may not realize that palliative care is optimal at this time and may continue to pursue life-prolonging treatment. So let me move on, but just, I think you've got the message here. Okay, so where we want to go is shared decision-making. And in other cultures, the patient actually, and I worked in India briefly some years ago, actually defers all decision-making to the family. So it's a very different structure, whereas here we're more focused on individuals in the West, and the individual wants the information to make their own decisions for themselves. In other cultures, and it's important to be aware of that, that decision-making may be done in a different way. So let's go back to Shirley. So ethically, your obligation, and the hospital doctors forgot that, your obligation is not Claudette. Shirley is your patient. And in fact, the doctors in the hospital are breaking Shirley's confidentiality by talking to Claudette. They should have talked to Shirley first and said, listen, we have some news about your illness. Do you want us to share it with you? Shirley might say, no, I don't want to hear. Talk to my daughter. That's fine. But Shirley might also say, don't tell nobody else. I just want to hear it myself. And I will tell other people. So right there, that's an ethical breach that happened in the hospital. So you are not to be following that. Your obligation is to Shirley. So what are you going to do? First, you have to talk to Claudette, though, and find out what's going on with her and what is she worried about. And I think we already know she's worried about that if her mother knows what's going on with her, she's going to fret more. However, you have to say to Claudette that I can't look after Shirley unless she understands what's wrong with her. And I will talk to her in a way that is gentle and kind and compassionate. And if I will find out how much information she wants, and if she really still doesn't want to know, that's fine. But I can't really care for her without Shirley understanding what's going on. She may defer all information to Claudette, and that's fine. and then you continue to care for Shirley, but you need to offer her the opportunity to understand what's going on. And I will say to you that, importantly, uncertainty is much worse than bad news. After 21 years of working in Jamaica in the public sector, I've probably met 3 or 4 people who actually don't want to know what's wrong with them. Everybody wants to know. You break the news in a calm, kind way. There's all kind of protocols out there that you can look up. Spikes is one of them. But uncertainty is a really bad place to leave people unless that's what they choose. Okay, so let's move on to Ivy. So Ivy is 87. She's a nursing home resident. She has severe dementia. So right there, bells are ringing. What's her competence and decision-making capacity like? She is still able to eat, soft diet, but now over the last 2 weeks, she's becoming more agitated. The nursing home is calling you to say she's agitated, combative. She's barely taking anything. All her relatives live overseas. I think we know that scenario. And her eldest son is like, calling you from Manhattan and saying, you do everything. Yeah, man, everything. I'll be back. I'll be down in a week, but she have to go to hospital. She need a brain scan. She need tubes. And if she stops breathing in hospital when she's there, you have to resuscitate her. How do we move forward with that kind of situation? So the first thing is, did Ivy have any form of advance directive, living will, or a conversation with her family that if she were to become incapacitated, that these would be her wishes? Then we have to think about what's her likely prognosis, which doesn't seem to be very good to me. What are the benefits of placing a feeding tube? What are the burdens of placing a feeding tube? And do we think it would be ethical to do so? So of course, this is not a decision that is going to be made by you and the son on the phone. This has to be a bigger discussion. Are there other relatives? Does anybody remember what Ivy said? Maybe she didn't tell anybody anything. But let's think about what would be in the best interest for this lady. There's lots of evidence that putting a feeding tube in somebody with advanced dementia is actually contraindicated. I don't have time to go into that evidence, but there's other ways that we can manage Ivy. We probably need to give her something, some sort of medication to try and calm her down so that she's not harming herself or others. And can we keep it simple? Can we offer her small amounts of fluid? Can we call her family to say, look, this is not looking so good? Can we have a conversation with the son to get him to understand? Can we invite him to come and visit his mother, and so on? And it doesn't mean because we're not doing active aggressive care that we are giving up on Ivy. It means that we're managing her appropriately, and she's not competent to make a decision. So we as the team have to come up with the best way of managing this patient. And a lot of getting to that point is about communication and conversation and listening. And giving information. Okay, let's talk about Dennis. So Dennis is 75. He has metastatic prostate cancer, and it's now mets to lung and bone, which is usually where it goes first in the prostate setting. So he has been in hospital. He went in with shortness of breath and severe pain. He's there for 10 days, and he's on immediate release morphine, and he's been given that every 4 hours, and it has worked very well in the hospital. His pain is much better, and his breathing, although not perfect, he's much calmer. He can breathe more easily, and he's discharged home, and he does have a follow-up appointment in 4 weeks' time. However, 2 days after he's back home, one of the family members calls you and says everything coming back, and you know, one of the things that should be taken back to hospital, and Dennis is like, absolutely not. So you go to the house, you do a home visit, and you realize that his wife is fretting because she don't like that word morphine. She knows said that when you give that, the person will go dead soon, and that they're surely going to be addicted. And so she stopped it. Okay, so I think, again, this is a conversation that you're going to have with his wife. She has a lot of unfounded fears. Hopefully you do not have these fears, but you should by now know that giving people with advanced cancer regular opioids is not going to cause addiction. The incidence is less than about 1%, in fact, particularly if people don't have a prior history of addiction. So morphine is very good to treat breathing, not because it depresses respiration, but because it reduces the subjective feeling of dyspnea. And so what are you going to do? You're going to talk to his wife and help her to understand that that's not what's going on, and that in the hospital setting and also perhaps in the community setting, we can talk about the ethical principle of double effect. And this is to understand that you're giving the morphine with an intention to relieve suffering. You are not giving the morphine with the intention to bump off Dennis or to cause him to be addicted. And there's a way that you can speak to, firstly, understand this yourself if you don't, but then to speak to his wife about the importance of using this medicine, and that there's zero evidence that it's going to send him off quicker, and there's zero evidence or very little evidence that he is going to become addicted. So this is where you as an educated professional are going to be able to have a conversation with Dennis's wife, because in fact he can be managed at home with the appropriate dosing of the medication. And so I'm going to wrap up there and just say, you know, serious illness decision making is a complex process. The only way you're going to get to it is by decent communication. You need to have the ethical principles in the back of your mind. And in order for people to be autonomous, they need information. So if they don't have information, we can't even move forward with the first ethical principle. And there's many different communication strategies. You can go online. There's endless ways to have serious illness conversations and to break bad news. Always use open-ended questions. And listen to what people are telling you. And on a personal note, start becoming an advocate for yourself and your family members in case, and you know, something serious happens to you. Did somebody know what your wishes were before it happened? This is like a dinner table conversation when everybody's relaxed and calm, and you can even laugh about it. So that's the end of my talk, and thank you for listening, and thanks to the organizers for inviting me today.
Thank you very much, Dr. Dingle Spence. Really great presentation. We learned a lot, very practical and applicable to us as general practitioners, family physicians. We're going to move now to the sponsor's presentation now for about 10 minutes.
All right, so the current sponsor's presentation is from Arista Pharma and Torrent Pharma.
A small seed marks the beginning of a full-grown tree. When a little bird drops a seed on the soil, it starts to germinate and gradually turns into a full-grown tree full of flowers and fruits. With a similar potential like the seed, in 1986, a small organization was founded under the dynamic guidance of Mr. M.A. Hassan, a visionary entrepreneur of Bangladesh. That small organization, Arista Pharma, is now a huge family of around 7,000 members. As one of the top 10 pharmaceutical companies in Bangladesh, Arista Pharma has a vision to provide better healthcare for the society by manufacturing and marketing quality medicines at affordable price. The journey started through the formation of a proprietorship firm with the introduction of a few products in oral liquid and tablet form. Today, Arista Pharma holds two big plants, one in Shampur Kotumtali Industrial Area, Dhaka, and another in Gotcha, Ghazipur. The Shampur plant was initiated in 1990 and over time extended in different phases. The plant holds manufacturing facility of a wide range of therapeutic classes like antibiotics, anti-ulcerants, cardiovasculars, anti-diabetes, antihistamines, laxatives, vitamins and minerals, etc. The WHO-approved CGMP guidelines are strictly followed in every single operation of the plant. The ultra-modern fluid bed processing technology from GLAD, Germany, integrates all the jobs of mixing, granulation, drying in a single programmable logic control machine. Inhaler facility. Aristo Pharma continuously strives to introduce a truly world-class pharma technology, and as such, Aristo Pharma came out as the first manufacturer of HFA inhalers for asthmatic patients in the country. Aristo Pharma's HFA inhaler manufacturing machineries are brought from Leal of Spain and Panasol of Switzerland. Biotech facility. Biotechnology is associated with a landmark breakthrough in new medical therapies to treat diabetes, hepatitis B, cancers, etc. Understanding the importance, Aristo Pharma has set up a high-standard facility for crystallization, filling, and sealing of its insulin products. Moreover, to retain appropriate storage temperature, it maintains complete cold chain throughout the distribution network with specialized vehicles. Research and Development Facility. Aristo Pharma's Research and Development R&D team regularly conducts study of new formulation design and develops the designed drug which supports the valued customers with advanced and latest medicines at affordable prices. Inspired by the philosophy Quality by Design, Aristo Pharma's Research and Development Department develops a wide range of generic products every year for the betterment of the healthcare sector at home and abroad. Like the big tree that evolves from a small seed, Aristo Pharma stands today as a confident name for millions of people at home and abroad. Aristo Pharma wants to move forward with the dream of a healthier tomorrow by serving millions of people and through the sincere efforts of its employees.
Good day, everyone. I hope you are having a good symposium thus far. Today, we at R.A. Williams wish to highlight a few of our products that you may find useful in your practices. First up, we have our antimicrobials that are widely available and accessible to your patients. We are excited to introduce to you our Tinibo, which is our tinidazole 500 milligrams, and our Ciprobid, which is our ciprofloxacin 500 milligrams, both created by Zydus Cadila. Tinibo is our anti-trichomonal agent. It is a prodrug with anti-protozoal properties. Tinibo acts through the formation of free radicals created by the reduction of tinidazole by the ferredoxin-mediated electron transport system that exists within the cell membrane. Once converted, the free radicals cause damage to the DNA, which results in programmed cell death. So, when it comes to non-gonococcal urethritis, bacterial vaginosis, and mixed vaginal infections, think Tinibo. Tinibo offers significant benefits to your patients. These benefits include fewer GI upsets, lower incidence of metallic or bitter taste when compared to metronidazole, smaller capsules, and a shorter course of therapy compared to metronidazole. Next on the list is our Ciprobid. And we just want to remind you that Ciprobid is our ciprofloxacin 500 milligrams. And always remember the dose is in the name, 500 milligrams BD. Now finally, we would like to use this opportunity to highlight HB+. HB+ is formulated with 15 milligrams of cyanocobalamin and 1.5 milligrams of folic acid, which are essential for red blood cell development. In HB+, we also have 350 milligrams of ferrous fumarate, which aids in the formation of hemoglobin, and of course vitamin C at 150 milligrams, which improves overall absorption. HB Plus, as mentioned before, is widely available and costs less than $40 per capsule to each patient. On behalf of everyone at RA Williams, we would like to thank you again for having us, and we genuinely hope that you enjoy the rest of the symposium. Thank you. Goodbye.
All right, we say thank you from our sponsors. Back to you, Dr. Brickell.
Okay, so to introduce our next speaker, who is Professor Figueroa, well known to us, a professor of public health, epidemiology, and HIV/AIDS. He has been a national epidemiologist in Jamaica and has done a lot of work regarding immunizations. For example, he is chair of PAHO's Technical Advisory Group on immunization, and he was a member of WHO's Strategic Advisory Group of Experts on Immunization. And more relevant to his talk as well, he is a member of the WHO Working Group on COVID-19 vaccines. And we know very well that he's widely published and has received many awards. So today he'll be talking to us about ethical issues rather, concerning COVID vaccination. Thank you, Prof. Figueroa.
Okay, thank you, Sophie. And thanks for inviting me to give this talk on ethical issues concerning COVID vaccination. So, as Sophie said, I'm a member of the Working Group on COVID vaccines, as well as on the WHO group on composition of COVID vaccines. And I chair both the PAHO Technical Advisory Group and the Caribbean Immunization Technical Advisory Group. So I'm going to say something briefly about public health ethics. We've heard two excellent presentations which have already spelled out the important principles to do with ethics. And then I'm going to touch on two important global ethical issues to do with COVID vaccination and a number of national ethical issues. And I'll spell these out when I come to them. A quick definition of terms: ethics, it's the exploration or study of human behavior that is considered to be right or proper, as against wrong or improper. When we aim to be moral, we are trying to conform to a standard of right behavior. And it's important for us to recognize that underpinning all of this is our values. These are our principles, standards, or beliefs that we hold to be important. We've touched on the essence of medical ethics, the importance that we're always striving to do good and avoid harm. But in so doing, we must show respect for persons, their autonomy, and this is why also we want informed consent for whatever we are doing with them. And then justice or fairness is so important. Now, Nancy Cass points out that we really also need to examine and consider the moral dimensions of public health practice and public health research. And that is what I'm going to explore a bit with you this morning. In doing so, we need to recognize what are the core challenges that we face in public health. One of them is the fair distribution of resources, because there's so much inequity in the world. And then there's a question of balancing the rights of the individual and those of groups, the community, the society. Promoting efficiency while recognizing the special standing of those in greatest need. Now, LAP says individual rights can be compromised for community interests, but only when there is proportionality. The benefit must be larger than the sacrifice. Beauchamp points out that public health has its own set of moral priorities, and these are critical to the functioning of a civil society. So there's social justice and solidarity. This is an awareness of being part of a community. And community means we have shared commitments to one another. And Beauchamp points out that market justice, the way that the market operates, can plague attempts to protect the public's health. Now, there is a code of ethics for public health that was published in the American Journal of Public Health in 2002. There are 10 principles. And I'm going to read these quickly. We must seek to address the fundamental causes of disease and requirements of health. Achieve community health in a way that respects individual rights. Ensure input from community members. Work for empowerment of disenfranchised, ensuring resources for access to health. Seek the information needed for policy and programs. Inform communities and obtain consent for programs. We need to act in a timely way with the information at hand. Incorporate a variety of approaches that respect diverse values, beliefs, and cultures. Implement programs in a way that enhances the environment. Of course, protect confidentiality, ensure professional competence of staff, and build the public's trust and the institution's effectiveness. Now, this is the code of ethics, but underlying the code of ethics are a set of values and beliefs. And I'm going to read these quickly. Humans have a right to the resources necessary for health. And we are inherently social and interdependent. The effectiveness of institutions depends heavily on the public's trust. Collaboration is important. People and their physical environment are interdependent, and each person in a community should have an opportunity to contribute to public discourse. Identifying and promoting the fundamental requirements for health in a community are of primary concern to public health. Knowledge is important and powerful. Science is the basis for much of our public health knowledge. People are responsible to act on the basis of what they know, and action is not based on information alone. Now, the UK Faculty of Public Health outlines some core values for public health, and I think we can agree with all of these. We strive to be equitable, empowering, effective, evidence-based, fair, and inclusive. But I would also like to add that we need to consider and include that we strive for social justice, respect rights, promote individual responsibility, solidarity, protect the vulnerable, and regulate the powerful. And these two in particular are important because if you don't regulate the powerful, they may take advantage of the vulnerable who are in the margins of society. Now, Dr. Bailey touched on this about different frameworks for analyzing ethical dilemmas. He spoke about the utilitarians who judge dilemmas by their consequences. There's also the liberals who focus on rights and opportunities, and those who take a more community orientation in order to promote community solidarity and social order and virtues. Now, I don't like taking, in my own analysis, I don't like taking just a unipolar approach. I prefer to promote a consultative dialogue. So you have an analytical framework in which you outline and make explicit what are the values and principles that we are striving for. What is the evidence that we have, the experience that we have, and that we recognize expertise in the field is important. And then we come to our best judgment in relation to our ethical dilemma. So let's look at the two key global ethical issues to do with COVID vaccines. The first is the significant global inequity of access to COVID vaccines, diagnostics, therapeutics, and essential supplies. But in addition to that, there is a global inequity in the burden on low and middle income countries compared to the richer developed countries. And many of the multilateral organizations like WHO recognize this and try to address it, hence the WHO values framework and roadmap. Now, we're familiar with the COVID pandemic, 3 years. In the first 2 years, significant number of deaths. In early 2022, you can see a significant peak, increased cases confirmed, and this is when Omicron began to circulate. And more recently, a subvariant of Omicron peaked, but there was a small peak in deaths, but not as many because immunity in the population was much higher. We have nearly 800 million confirmed cases. That's obviously a gross underestimate of the real number of cases, nearly 7 million deaths reported, but the estimated excess deaths is 2 to 3 times higher than that. And over 13 billion vaccines, COVID vaccine doses have been administered. But you know, 70% of the world population has received at least one dose, but only 30% of the population in low-income countries. We know the impact on development has been serious. Aside from the death and disease and the long COVID, there's been an increase in poverty, hunger, unemployment, significant declines in GDP, severe setback in education in children and young adults, increase in mental illness, physical and sexual abuse, a decline in routine immunization coverage and therefore the risk of outbreaks, major setback in development in low and middle income countries, and an increase in global inequity. So all of these raise important ethical issues. How do we recover given such a pandemic? And that is important. How do we use our scarce resources? Many people may not realize, this is data from the US, but since the financial recession in 2008, you can see inequity has been increasing where the top 1% of persons who have wealth, it has been growing. And when the pandemic came, this accelerated significantly. And the bottom 50%, their share of wealth has remained largely static. Okay, now most of the vaccines that have been given were given in 2021 and the first quarter of 2022. But this shows the huge inequity in access between vaccines in developed as against underdeveloped countries, but more so the burden. High-income countries only needed to increase their budget by 0.8% in order to get vaccines for 70% of their population. Low-income countries had to increase their health budget 56% in order to cover the cost of vaccinating 70% of their population. So this is the burden, the inequity of the burden. The multinational organizations did set up approaches to try and improve access to diagnostics, therapeutics, vaccines, and strengthening weak health systems. The COVAX facility actually aimed to deliver 2 billion vaccine doses by the end of 2021, largely to low and middle income countries. And this is just a graphic to show that You have the COVAX allocation mechanism, but the working group on COVID vaccine, which met virtually weekly for 2 years, the first 2 years of the pandemic, felt that we needed to look at what are the values that we're going to base the prioritization of access to the vaccines. So there was a work to develop a values framework and then to identify who should get the vaccine first. And then as the vaccines came on stream, you'd have vaccine-specific recommendations. So why a values framework? Because you needed to think through the competing needs and interests, given the limited supply of vaccines. You need to minimize the risk of overlooking morally important uses for the vaccine and claims on vaccination. And you also wanted to increase accountability through clear and explicit reasoning. What was the goal? The goal was that COVID vaccines must be a global public good so that it can contribute on an equitable basis to protecting and promoting human well-being among all people of the world. What were the core principles underlying this? Human well-being, global equity, reciprocity, equal respect, national equity, and legitimacy. Reciprocity is the principle where those who are carrying the greater burden should be recognized, so people like health providers who are on the front line are putting themselves more at risk. They need to be taken into account early. Legitimacy means let us base our distribution of the limited supply of vaccines on the basis of evidence, clear criteria, and transparency, communicating the basis on which prioritization is being proposed. So this takes us now to some of the key ethical issues that we had to face at the national level. And this includes who gets the vaccine first, and the WHO roadmap based on the values framework made suggestions that could help countries decide. We're going to look at vaccine confidence and hesitancy, misinformation, vaccine mandates, and vaccine coverage. So initially, when the roadmap, the WHO roadmap came out, the priorities were to give the vaccine first to older adults and healthcare workers, groups with comorbidities. And then we still need to bear in mind the essential workers on the front line and groups unable to socially distance. As the pandemic, we got more experience, and as the pandemic unfolded, we realized that persons who had immune deficiencies were very important. They were more at risk. They fell within the groups with comorbidities, but also what we did not appreciate adequately initially until we got the experience is that pregnant women were at higher risk and therefore deserved also to get the COVID vaccine early. The rationale for vaccinating older adults first was clear. The death rates increased significantly with age, as do comorbidities. And its age is a good, easy way, criteria to judge who should get the vaccines first. And life shows the studies that were undertaken, for instance, in the UK, looking at hospitalization, you can see that persons who were vaccinated were less likely to end up in hospital, but that the pattern increased significantly with age. So persons over the age of 60 and especially 70 and 80 were much more likely to end up in hospital. Okay, sorry, I'm going backwards. This shows you that by the middle of 2021, because the UK were unrolling rolling out one dose of the vaccine and had achieved a coverage of 61%. When the Delta variant hit them, the number of deaths did not increase significantly, although the number of cases surged tremendously. Let's now turn to the question of acceptability of the COVID vaccine. A survey was done by Johns Hopkins in 67 countries across the globe. And you can see these blue bars indicate the acceptability, and it ranged from just over 30% up to over 80%, depending on the country. If we focus on the Americas, countries like Brazil, Ecuador, Venezuela, over 80% of people wanted the vaccine. If you look at Jamaica on the extreme right, only 35% said that they would accept a COVID vaccine. This was before the vaccine was actually available. Many people had concerns. They were worried about that the development of the vaccine was too rapid, the trials were too short to assess safety. This new mRNA technology had them concerned. They noticed that the virus was mutating and it does not behave in the same way in different countries. There were questions, how long will vaccine efficacy last? All of this was complicated by a variety of conspiracy theories and significant misinformation. I don't have a slide, but one study showed an analysis of some of the social postings, social media postings, that the significant misinformation was driven by about 10 different sources in the US. And virtually all those sources had a vested interest in providing misinformation because they could provide alternate therapies that they could market. And it was not clear that this was the case. Now, even among immunization staff in the Caribbean, a quick survey was done before vaccines came, and as many as 74% of immunization workers were concerned about vaccine safety, and 42% concerned about vaccine efficacy and herd immunity. At the time, many of us tried to explain that COVID vaccines had been, research was going on for decades, and that the SARS and MERS outbreaks stimulated further research, and that the technology had become more sophisticated, but it did not really answer the concerns that many people had. Also, many people do not realize the stringent regulatory process that new vaccines have to undergo. And even with the WHO emergency use listing, it's not automatic. It's quite a stringent process, but people are not necessarily aware of these processes to help ensure the safety of the products. Now, this is a slide that comes from December 20, when the vaccine was just becoming available. And in my educational talks, I pointed out the duration of vaccine efficacy is not known. We don't know if the effectiveness of the vaccine may decline or increase over time. And the vaccine may prevent disease, but not transmission. I share this slide because it is important that you are transparent in promoting a new product. And then in early March, it became clear, and this is a slide from that time, that low developing countries at most would get only 60% of the vaccine supply for their population by the end of 2021, showing again the inequity of access to the COVID vaccines. And this graph shows you that in February 2022, while upper middle income countries and high income countries had achieved significant vaccine coverage of their populations, Low middle income countries were much less, and low income countries had hardly got started, showing you the inequity of access. Now, an important concern arose because of the adverse events of the vaccines, the thrombotic thrombocytopenia syndrome from the adenoviral vectors vaccines, the anaphylaxis and myocarditis from the mRNA vaccines. And there was a vaccine trial where they suspended it because they were concerned about safety, and then they investigated and proceeded with the trial. Of course, AstraZeneca in some countries was suspended and put in an age criteria. The J&J vaccine manufacturing plant in the States was closed down for reasons that it didn't meet standards. And once the vaccine was being rolled out, some people had a reaction to the vaccine. It may only last a day or two, headache, fever, fatigue, but this had many people worried also. So these are genuine concerns aggravated by various rumors and misinformation. So it was a very hard sell to explain to people that you have to weigh the benefit of the vaccine against the risk of adverse events. And in fact, 30 to 50% of persons who develop severe COVID would actually get thrombosis that, if not treated, could lead to death, whereas TTS may be 4 cases per million doses. But people don't necessarily work out the mathematics of these things. There were some important studies. The Kaiser Permanente study showed that cumulative incidence in terms of COVID diagnosis was much higher in persons who were unvaccinated in blue than those who were vaccinated. Likewise, hospitalizations, much higher, and persons dying, much higher in persons who did not get the vaccine compared to those who did get it. And this is other data showing that persons who were vaccinated, if they were elderly over the age of 65, then maybe only 20 per 10,000 hospitalizations, the same as vehicle crashes. But if you are not fully vaccinated, it was nearly 400 hospitalizations per 100,000 people. And data from Switzerland also reinforce this. The unvaccinated were more at risk. And Fauci added it up succinctly. If you are vaccinated, the risk of infection was 1 compared to 10 in those unvaccinated. Hospitalization risk 1 to 17. Risk of dying 1 to 20, hence the value of the vaccination. And more than 1 million deaths are assessed to have been averted in US alone, and 10 million hospitalizations. But people don't necessarily make these calculations when they hear the various rumors about and the actual adverse events concerning vaccines. Now, an important issue that came up that I'll try and deal with quickly was whether we should introduce mandates. And this came up in February 2022 when vaccine coverage was not really increasing quickly. Now, in general, mandates are effective for vaccination, provided there's good access to the vaccines, an established safety record, and reasonably widespread support. And if you look at the experience with influenza vaccine, many hospitals now in the United States require health providers to have a flu vaccine because health providers who develop a cold frequently still come to work, and they may pass if it's flu, they may pass it on to their patient who is already sick. So based on the principle of doing no harm, professional duty, the need to protect those who cannot protect themselves, as well as to set a good example, the hospitals insist that the health provider gets the flu vaccine. Well, you could apply that also to COVID. Now, if you look at the general population, the kind of questions you have to ask yourself, was there good access to vaccines in place so that you could get it readily? And I don't think this was really the case. I think the safety record of the vaccines was reasonable and that was established, but not everybody believed it. The benefit of the vaccination definitely outweighed the risk, but there was not widespread support and vaccine coverage was still relatively low. And given these factors, I was not really in support of a vaccine mandate for the population in early 2022. Some workplaces took a high-handed approach, insisting that their workforce get vaccinated and ended up in court. Other workplaces took an ethical approach, consulted with the workers, educated them, facilitated vaccination, implemented a policy requiring vaccination, and they achieved over 90% coverage in Jamaica. And I'll end with this slide, which shows you the different vaccination coverage towards the end of last year throughout the Caribbean and in the United Kingdom. And, you know, it is sobering that Jamaica is at the bottom of the pile. We're still at about 30% vaccination coverage. Only Haiti in the Caribbean is lower than us. Cayman Islands is 95%, BVI is over 90%. It shows you that in the Caribbean, you can get people to take the vaccine, but unfortunately, we were not able to achieve that. These are some of the issues that we have to reflect on and learn the lessons. I thank you.
Thank you very much, Prof. Figueroa. We're going to go into the question and answer section, which is about 10 minutes. And we are encouraging participants to put questions and answers in the Q&A chat. We won't be able to answer live questions, verbal ones, but once you type it in, we can facilitate the speakers answering. So I'll try to go to the top of the Q&A. There was a question, I think, by Dr. Bandarako. I'm not seeing it now for Prof. Bailey, about whether the ends justify the means or the means justify the ends. I hope I got it right, but I'm not seeing it now. I think that was for the first speaker in the section, Prof. Bailey.
I presume that that question was addressed to me with respect to utilitarianism versus the ontology. As Prof. Figueroa said, these are difficult matters, and one has to approach each case and make a decision based on merit, because all of the ethical theories have their pros and cons. And my main takeaway point from this discussion is what I describe as care-based ethics, that irrespective of whether you believe that the circumstances or the consequences merited, whether you believe that you have a moral duty to do what you have to do, and many of us actually also have a strong spiritual ethos that guides us. At the end of the day, if you give off your best to the patient, and I'm really Aristotelian in terms of virtue, if you're compassionate, understanding, caring, and kind and gentle, and if you understand the patient's point of view, then you do what is right. That's how I see it.
Okay. Thank you, Prof. Bailey. There's another question comment from Dr. Bandara Kaur, but I'll just read it quickly because I think Dr. Dingle Spence would have addressed it. Is the best interest at end of life always focus on preserving life? In our experience, I think the best interest is better served by honoring the patient's wishes where they have been expressed and offering comfort and dignity rather than seeking to preserve life at all costs. I think Dr. Dingle Spence covered that, so I'll go to the next question for her, for Dr. Dingle Spence. With regards to informed dissent, what is the risk of litigation if, for example, after refusing a treatment, the patient has a poor outcome and the patient or family decides to sue? Listing every possible poor outcome may not have been done, therefore doesn't informed dissent increase the risk of litigation for practitioners? Though I know once corpus mentioned, we cannot force patients to accept recommendations against their will. So that's for Dr. Dingle Spence, I believe.
Thank you. I think this points to the absolute importance of documentation. You know, I've certainly looked after many people who have informed dissent. It's very, very common in the cancer space. And your duty as a physician is to make sure that all options are presented to the patient and the pros and cons of each option. And then, you know, once people are competent, then they obviously have an absolute right. And my concern is more the opposite, in a way that, because many of our colleagues say, oh, well, if I don't do this or do this treatment, they could sue me. And I would actually say, boy, they could sue you for not referring to palliative care and pushing with aggressive treatments. So I think, you know, I do think a lot of it is around, you know, conversation and communication, but also documentation. So if you document very clearly that this conversation was had, if you even feel like, whoa, this is a patient and family that you're feeling a little bit uncertain about, you may even want to say, you know, when you're having those difficult sessions, ask permission to record them, so that nobody can tell you that you didn't give the best advice out there. So it's back to communication documentation, I would say.
Thanks, Dr. Dingle Spence. I'll ask another one for you, one more. Thoughts on assisted death as an end-of-life choice option, especially in ailments with no cure / treatment with progressive total dependence on individuals, machines, etc. burden?
Well, we could speak all day on that one. In Jamaica, as I'm sure you are aware, neither euthanasia, which is where the doctor actually gives you something that with the intention of ending your life, nor medical aid in dying, where the doctor gives you something that you can then take when you feel like you want to end your life. Neither of those things are legal here. I think that there's a place for discussion about it, particularly what we call medical aid in dying, that used to be called physician-assisted suicide. So there's places in the US where that is legal. In Canada, it's completely legal, medical aid in dying, but it's not without a very long and deep consultation process. So you can't just go to your family doctor and say, I've had enough, can you give me something to take my life? So I think there's room for discussion. I think that in our country and probably in the region, there's a lot of religious thought that would preclude us wanting to go down that path in our country. But that doesn't mean that we shouldn't have a conversation about it. Yeah.
Thank you. Just to go back to Dr. Bailey, just for a quick minute or two, I think this is more for you. In the case of a non-compliant patient who was repeatedly non-compliant, for example, with their diabetes care, and they still are coming to visits with hyperglycemia, this doctor is asking, or person is asking, what's the best way to proceed with that type of patient?
I suspect that that question would have been asked, because that's an ethical issue I have to grapple with almost on a daily basis. And my response to that is that you need to document what is happening between you and your patient. One escape route you could adopt is to abandon the patient and invite the patient to seek care from someone else. But the level of bonding that we have with the patient is so strong that abandonment to me is not an option. Having determined that the patient is competent and is appreciative of the nature of the illness and the fact that the treatment being offered is not proven to be as effective as it should be, and having advised him of the consequences of failure to add additional treatment option or to change the option because of their own value system and fears of complication. My suggestion is that you record all of this carefully in your notes indicating that you have told the patient clearly what the consequences of failure to adhere to your recommendation is, so that you can at least indemnify yourself of any adverse outcome. It's really difficult. It's a really difficult situation when patients absolutely refuse to take your advice, but insist that they want you to care for them. My recommendation in this case is to continue to advise, to encourage, and to try and initiate behavior change over time. But while they're trying to make up their mind, ensure that you document the discussion so that if any adverse effect occur, you can be indemnified.
Thank you, Prof. Bailey. I may not be able to go through all questions. There's one by Margaret Wong Bino, but I would ask the panelists if they don't mind, if there's anything that's not answered orally, if they wouldn't mind typing if possible, for those questions that I wasn't able to get to because of time. But I will go to Prof. Figueroa. I see he's typing some stuff, but I'm not able to see it yet. But from Dr. Bandarakor, she asked, how much do you think people's distrust in public institutions and fears that the powerful were not being appropriately regulated make people so susceptible to misinformation?
It's hard to answer that because there was so much misinformation coming from different areas. It just wasn't from the powerful or from certain vested interests. So, but I think the bigger problem we faced is that there wasn't sufficient confidence in our leaders of all kinds in relation to what we were saying about the vaccine and that the benefit outweighed the risk. You have to have trust in your health services, your public institutions, and you have to have good dialogue with the people. You can't have you have to address their specific concerns in a respectful manner in order to win them to take a positive view. And I don't think that we succeeded there, unfortunately.
Thank you, Prof. And the last question from Dr. Bandarakor, are the benefits of repeated boosters for COVID-19 vaccine established? And does the risk of side effects from repeated boosters outweigh the benefits?
Yeah, the WHO has actually brought out a new roadmap which puts the emphasis on a periodic booster for the elderly, especially the very old, persons with comorbidities or immune deficiencies, and for pregnant women. So younger persons are getting much less benefit because people who have been vaccinated now and who have been further exposed to the new variants, their immunity, hybrid immunity, is quite good. So the use of the vaccine, I think, can be much more limited just to those who are at particular high risk. The truth is, we need a much, much better vaccine that is more like what we're familiar with the childhood vaccines. But it's going to take some hard work to achieve that.
Thank you very much to Dr. Dingle, Spence, Prof. Bailey, and Prof. Figueroa as usual. Very informative, very helpful to us. And thanks again. I think we're going to go now to our sponsors' presentations for about 10 minutes, because we're a little bit behind time.
All right, thank you guys very much. Now we head over to our sponsor, Indus Life Sciences. Mr. Dan is on. Sir, please share your screen and talk to the wonderful folks here at World Family Doctor Day.
Good morning, all. Mr. Spence, are you able to see my screen?
Yes, we can.
Thank you. Greetings to all, to the participants, presenters, moderators, and sponsors on behalf of World Family Doctors Day 2023 from Indus Life Sciences. And those who are not familiar with Indus, we are a pharmaceutical company based in 3 Carifta Avenue, Kingston 11, INDUS basically stands for I and us. I and us together serve the community, that is INDUS. So today I just going to refresh one of that drug which introduced last year, which is over the counter. And those who are not familiar with this product, probably this presentation will help you to understand it. So this is for the people who suffer from heartburn, hyperacidity, gastritis, flatulence like gas problem, acid reflux, and pain associated with gastritis. And not necessarily when these people have this problem, you have to start with an H2 receptor blocker or a proton pump inhibitor. Even sometimes a simple antacid can give a wonderful results for them. But the challenge is that when we talk about antacid, when if you visit the pharmacies, we'll see different label of antacids in the pharmacy. So we get confused which is the right antacid to recommend. So for that, you know, the antacid has been classified as generations. So when you understand the generation, you will understand and how we could recommend or choose the right antacid. To understand it, the first generation of antacid or the basic antacid, but I'm not pretty sure these antacids are still available in the market, but these were the first antacids that were introduced, and they're meant to to neutralize excess acid in the stomach, which is we call as hyperacidity. Basically, it offers medications like magnesium hydroxide, aluminum hydroxide, and magnesium trisilicate. But unfortunately, these antacids has a lot of gaps. As we saw in the first slide, in conditions like ulcer, it is not only acidity that is involved. There are other complications like gas problem. A lot of people suffer from excess gas problem, burping like condition, and many of them has this acid reflux. Almost 8 out of 10 suffer from acid reflux, which medical terminology is called as GERD, gastroesophageal reflux disease, which is also quite high. And pain is a basic symptom for ulcer. This older antacid has no answer for them. That's why the second generation antacids are introduced. And what we currently see in Caribbean, I don't say Jamaica for that matter, the whole Caribbean, if you see the antacids that we see that has been introduced, that has been seen in the market, they are classified as second generation. And this second generation has a little benefit over the first generation because they neutralize acidity. Additionally, they have dimethicone or simethicone. The role of this medication, dimethicone or simethicone, is to relieve the gas. So they are good to conditions like flatulence as well as excess acid secretion. But if you look at it closely, as you could see in this slide, the gentleman is suffering from a condition called as GERD, which is nothing but acid reflux, which is basically the stomach acid content is thrown up from the stomach into the food pipe, esophagus. So that causes a heartburn condition. And if it happens at bedtime, some of the people even get concerned or worried or confused, thinking they're suffering from heart attack. So GERD is a condition which is quite common. Almost 8 out of 10 ulcer patients do suffer from that. The second generation antacid has no answer for it. By the way, whatever brands that you see today in the pharmacies, they all fall under this category of second generation antacid. So there is a need for a newer antacid. That's where INDUS has introduced a new antacid, which is available currently across Caribbean, not only in Jamaica, even in Cayman, Bahamas, Guyana, Barbados, and other Windward Leeward Islands too. So which is we call as new gel. This has a unique ingredient, which is alginic acid. Some of you may be familiar with this alginic acid, which is basically an algae. This alginic acid is an algae. What happens when anyone takes this antacid new gel, this alginic acid in new gel mixed with the stomach acid content and forms a raft or a foam, as you could see in the slide, that floats over the stomach acid, and it acts like a barrier, does not allow the stomach acid content move from stomach into the esophagus. So to make it understand it better, I have a little clip. If you see the clip, you will understand it, how this alginic raft prevents GERD or acid reflux or heartburn. So you could see in the next one. When patient takes this antacid new gel, as it enters into the stomach, the alginic acid in new gel mixes with the stomach content and it forms a foam, as you could see in this clip. And whenever acid on the stomach tries to move up into the esophagus, this foam, this raft formed with alginic acid prevents it. Thereby, the person will not have the episodes of GERD or will not have the heartburn. And this foam is formed in just 4 minutes and stays more than 5 hours. After 5 hours, it gets completely excreted along with the stomach content and no residue is left. So when the person takes the second dose, again the foam is formed, the raft is formed, again it prevents the GERD or acid reflux or the heartburn will not be there. Just to get it clear, let me play this clip once again for better understanding. As you could see here, the new gel enters into the stomach content and the alginic acid in new gel mixes with the stomach content and forms the foam, and this foam floats over the stomach acid, and whenever the stomach acid tries to move up, push into the esophagus, this foam blocks it. Thereby acid reflux or the GERD, which we refer it as GERD, is prevented. So no heartburn will be there and formed in 4 minutes, and it stays literally more than 5 hours, and after 5 hours get completely excreted. So this is the benefit of this alginic acid, and this is the first antacid in Caribbean offers the benefit of alginic acid. As you could see in the slide, it has a regular medications like magnesium hydroxide, aluminum hydroxide, magnesium trisilicate, which we all know neutralize excess acidity, and the dimethicone is good to prevent, the gas, which we call as flatulence, that is there. And good news about new gel, it is over the counter across Caribbean. No need for prescription. You can go to the pharmacist nearby, wherever you are, and you can ask your pharmacist, it will be in the shelf, you can pick it up. And another good news, the new gel, as you could see in the slide, it's sugar-free. So it's safe in diabetes. Those who sugar bag is full, they can safely take new gel, no issues. And also safe in pregnancy, thereby in the first trimester, second trimester, third trimester of pregnancy, wherever normally we know the episodes of, throwing up will be high during pregnancy phase. So it helps them too. When we say it's safe in pregnancy, obviously kids, less than 10 years of age can also be recommended new gel. And it comes in 2 pack size. What you see in the slide is 200 ml, the bigger version, which is roughly in Jamaica, I could say the pharmacy sells between $800 to $850 to the patient. And we have a smaller pack, which is 100 ml. That is also available for sales. And that one is priced somewhere around $500 per 100 ml pack. And very soon, maybe next month, that is in June, we are in May now, June, we are going to introduce 10 ml liquid pouch sachets. So that is easy to carry, especially those who travel or those who work in the office. You don't have to carry the bottle, you can just carry 1 or 2 sachets. Those who are going to restaurants, if you have little GERD after having your dinner or lunch, you can just open the 10 ml sachet and it's a ready liquid, you can just take it and drink it. And that will cost way lesser, maybe less than $100. So that will be launching it next month in June. So that will be the first company coming out with this 10 ml pouch too. So this is new gel, but we don't stop there. We actually have another presentation of this new gel, which we has a nickname called as mother of all antacid. So why we call it mother of all antacid? This offers the best benefits to your patients who suffer from gastritis, pain, stomach pain, ulcer pain, and acid reflux, GERD, and also gas problem, hyperacidity. This is one-stop solution, which is our new gel O, because it offers one more ingredient, which is oxytocin. As you could see in the slide, we highlighted in red. So this is a mucosal anesthetic agent. The role of this mucosal anesthetic agent, it gives a coating to the stomach wall, and thereby pain associated with ulcer, pain associated with gastritis will be relieved by this pain relieving medication oxytocin. So that's why we call as mother of all antacid. As you could see here, it stops GERD, it prevents acid reflux, it also stops heartburn associated with the GERD, and it neutralizes excess acidity, and it relieves gas because it has dimethicone, and it relieves pain, which is because of oxytocin. So, and this offers, the relief of pain kicks in less than 10 minutes, or in fact, less than 5 minutes, I could say. So, and this also comes in 2 pack size, 200 ml and 100 ml. And again, new gel O is also over the counter. So no need for prescription. If you can approach your pharmacist, so they can give new gel O. But only caution with new gel O or contraindication with new gel O is that It is not recommended during pregnancy because it has a pain relieving medication, oxytocin, and also not less than 10 years of age. If you come across a pregnant mother or a kid less than 10 years, better recommend them Nugel. If it is non-pregnant women and kids above 10 years of age, rest of the population, Nugel is the best antacid. It's sugar-free too, and it has mint flavor also. And the pack size of 200 ml in Jamaica is priced around $900. And the 100 ml pack, we do have it. That is around $600 down here in Jamaica. And it's available in all the pharmacies, length and breadth of the island, it is available. And we're also launching the sachet, as I mentioned, the pouch, the 10 ml for Nugel O will be rolled out next month. So it will be available in the pharmacies. So we'll be the first company offering Nugel O, both not only 200 ml, 100 ml, as well as in pouch formulation. So, and the indication is here, as you could see, gastritis, ulcer, heartburn, hyperacidity, pain conditions. And you can combine Nugel and Nugel O with your regular proton pump inhibitors like pantoprazole, lansoprazole, omeprazole, or even with your H2 receptor blockers like ranitidine, sematine, no issues. Remember, doctor, these antacids are not a substitute for them. It is basically is for symptomatic faster relief, and antacid will really help. So it can be combined with the regular anti-ulcerant medication. It can be combined with Nugel, and Nugel O can be combined. So this is our product, and just refresh you a couple of other brands. And we have, as you could see the picture, I know pretty well, flowers.
Mr. Danadan, please, time. Thank you.
Okay, sir. Okay, thank you very much then, no problem. Thank you, Mr. Sam. Good day. Thank you very much, doctors.
For a full range of modern eye care services, visit Ophthalmic Suites. We offer the latest laser technology in glaucoma care, LASIK vision correction, retinal and cataract surgery using premium implant technology, and so much more. From A to Z in eye health and vision care. Visit us at 34 Lady Musgrave Road, telephone 630-0958 or 759-6449. Ophthalmic Suites, Jamaica's eye care technology center. Do you feel trapped behind your glasses? Ever considered what life would be like to wake up to crisp, clear vision? LASIK vision correction may be just the answer you're looking for. At Caribbean LASIK Vision Center, our team of certified doctors and counselors are available for LASIK evaluation. Call us at 630-0958 or visit www.lasiccaribbean.com. We are conveniently located at 34 Lady Musgrave Road, CLVC, where technology meets the eye.
We say thank you to our sponsors, and we'll ask sponsors. I saw where there was a lot of chat going on in the chat group. Read the products that you shared with us. So thank you again. Thank you for making this possible. Hand over now to moderator for the next session, Dr. Arna J. Brown Morgan. Yay. Dr. Arna Brown Morgan, over to you.
Hi. Welcome everyone to the second session of the World Family Doctor Day Conference. I am your moderator for the next couple of hours. I just want to say thank you so far. It's been a wonderful morning. Some of the information shared has been even alarming, and of course some giving us responsibilities of what we need to do. I'm going to go right ahead right now and introduce our first speaker in this second session. And that is no other than Professor Winston George Mendez Davidson, CDJP, MBBS, DTM and H, who is the retired head of the School of Public Health and Health Technology at the University of Technology in Jamaica. And he's a public health specialist, well known for years, and family physician. And he's also a graduate of the University of the West Indies, Mona, and of Liverpool School of Tropical Medicine and Hygiene in the UK. In the area of public health, he is the original proponent of the 4 stages theory of prevention, which integrates the 5 pillars of wellness as a fundamental component of the process of the prevention of diseases, particularly related to the control of communicable and non-communicable diseases. So he is the leading applied researcher in the development and practice of telemedicine in Jamaica and the Caribbean. So we're going to hear more about this shortly. His platform, Doctor on Call, is a culmination of 25 years of research and development in the Caribbean. And Professor Davidson was chairman of the Bureau of Standards Committee for developing industry standards for the development of telemedicine here in Jamaica. This was launched on the 9th of February, which some of us, I'm sure, attended also. So this is pioneering work, which now creates the opportunity for Latin America and the Caribbean to integrate telemedicine within the global value chain. So it is my pleasure to deliver this audience into the capable hands of Professor Emeritus Winston Davidson to speak on EMR, the new art of medicine and its medico-ethical implications. Over to you, dear Prof.
First of all, thank you very much, Dr. Arna Brown. I am very pleased to be able to share with you the findings of the project that we have been engaged in for over 25 years. So I'd like to begin with the first slide.
Please go ahead and share your screen, Prof.
Let me share my screen.
Thank you so much.
The topic is electronic medical record, telemedicine, the new art of medicine and medical ethical implications. Of course, it's a wide topic. And of course, one has to be very careful lest one gets carried away with this topic. But let's see the first slide presentation. Next slide. First of all, let's look at some definitions. What do we mean by electronic medical record? An electronic medical record, referred to as an EMR, is a digital version of the traditional paper-based medical record for an individual, referred to in the past as the written SOAP notes. These SOAP notes, as you remember, that you take, they are the written record of the patient, of the relationship, the clinical relationship between the clinician and the patient. And it's the acronym for SOAP is subjective, objective, assessment, and plan. And these SOAP notes are taken, of course, manually, but we have a number of electronic systems where the SOAP notes can be taken by the electronic systems itself and referred to as an EMR. So it's a method of documentation employed by healthcare providers to write out notes in a patient's chart, along with common formats such as the admission note. And so therefore, the EMR represents a medical record within a single facility, such as a doctor's office or in a clinic. The EMR, electronic medical record, also represents the patient's record created in hospitals and ambulatory care environments, and which can serve as a data source for the EHR. The EHR now is the electronic health record of the patient, because each patient has a right and a responsibility to document his own electronic health record. For example, his weight if he's a diabetic or hypertensive, his blood pressure, his blood sugar, and he can document it as he feels. And that is his electronic health record, which can act as a guide to assist him in doing, in managing himself. In other words, it's personal management. And so therefore you have the electronic medical record, which is the professional record put in a particular systematic form, which is an electronic form, or the electronic health record, which is the health record of the patient as he monitors himself. Next slide. Now, the electronic or personal patient health record. An electronic personal or patient health record is health-related documentation maintained by the individual patient to which it pertains. And so therefore, the electronic personal or health record can also be a record of the patient generated and maintained within the institution, such as a hospital, integrated delivery network, clinic, or physician office to give the patients, physicians, and other healthcare providers, employees, and payers or insurers access to a patient's medical records across facilities. In other words, sharing of the different records by the particular patient. And doctors have done this routinely over the years, where, for example, you get the record from the nursing facility that where the patient has gone. It's not a doctor who has taken the notes, but the fact is that all of this documentation can be done across facilities and not necessarily with doctors, and also it can involve the patients. One very important thing that each doctor must understand, that in the final analysis, it's not the patient, it's not the electronic personal health record that is the important thing. The important thing is, what do you designate as the medical record of the patient. If you think, for example, that a patient is sloppy in the details of taking his blood pressure, or you may choose not to take that blood pressure because it will give you a wrong reading. You are where the buck stops, and you must decide whether you wish to incorporate electronic personal health records or patient health records within the electronic medical record that you have. Next slide. Now, the EMR in the United States. The US has lagged many other countries in the use of EMR in patient care. It is now changing with the implementation of the Health Information Technology for Economic and Clinical Health Act, which is the High-Tech Act of 2009. Next slide. To obtain incentive payments, providers must not only adopt electronic health record systems, but they must also make meaningful use of them to improve patient care. In other words, it's not simply translating paper records into electronic form, but creating an electronic infrastructure that would improve the healthcare system and the health of the respective Americans. Next slide. The Office of the National Coordinator of the Department of Health and Human Services reached a major milestone when it published regulations in July 2010 that sets forth standards to define the meaningful use of electronic health records. Standards stated in terms of the objectives, maintaining an active medication list for patients, measures for quality or qualifying for incentive payments. In other words, these are linked to the payments to determine exactly the cost of meaningful use. Next slide. Meaningful use continued. Meaningful use categories for physicians can be grouped into 4 broad categories. The contents of the EHR, electronic health record, the exchange of information with other providers or authorities, for example, e-prescribing. Thirdly, sharing information or communication with patients. And 4, decision support and patient protection. Conclusion. Medical software functionality must conform to the basic meaningful use criteria of these 4 broad categories, among others. Next slide. Now, let us move to a very important aspect now, the ethical aspects. And let me see if I can share my slide properly. Let's get rid of that green one. Okay. Yeah. The application of the principles of medical ethics. Listen carefully. The application of the principles of medical ethics is an essential and necessary condition for the practice of telemedicine. Now, what is telemedicine? Telemedicine in this instance is defined as the information and communication technology means and methods for the delivery of health and medical services to patients and clients in virtual space. In contrast to the normal clinical encounters by health providers, telemedicine may also be represented in practice as the virtual extension of your normal face-to-face clinical encounters. In other words, if you have a patient on your books, and that patient you see would come into your office for face-to-face, but that patient doesn't wish to come into your office as often as they did, they wish to see you remotely. You can register that patient that you have registered on your registered to come into your office. You can have him registered on your telemedicine platform, which is just a virtual extension of the registration that you have there. So you have all the notes available you have the notes available in your face-to-face encounter, and you will also have the notes available in your virtual encounter. This new condition requires new emerging medical ethical standards to ensure not only scientific validity, but most importantly, widespread user acceptance, credibility, confidentiality, and privacy. And so, therefore, you will begin to see that there are ethical aspects, though similar with face-to-face medicine versus virtual medicine. They are not the same and require added consideration of some of the ethical aspects. And that is what I'm going to consider this morning. Separate and apart from that, let's have the next slide. Hence, the goal of this presentation this morning is to share a number of findings from 25 years of research, development, and practical application of the research outcomes. In this instance, creating a virtual clinical practitioners platform referred to as Dr. On Call. So I'm using some of the findings from this platform to illustrate in a practical way the difference and the challenges between face-to-face medicine and, of course, medicine practiced in virtual spaces. Now, this platform is designed to enable the embodiment of two very important principles. The first principle is a universal principle. And I'll show you why these principles are used as, in fact, the background of the whole study and the whole research. The first principle is a universal principle. We were not interested in producing a platform for the use of people in general, the majority of Jamaicans or the majority of persons who use it, if it is not affordable and if it is not accessible. Now, obviously, if you do not have an electronic system, that is to say, if you don't have internet, if you don't have broadband, if you don't have all of these things, you're not going to have, the services are not going to be accessible. It so happens that Jamaica was one of the most accessible from an electronic standpoint countries in the world, because, of course, you know that the internet penetration was in the top 1 or 2%. The second is the incorporation of the United Nations One Health principle. I will elaborate on that, what I mean by the One Health principle, because it enables the integration of the delivery and management of healthcare processes and services in support of the human, animal, and climate change ecosystems. That is where the unity comes in. In other words, the whole philosophy, the whole understanding of an attempt to try to see if we can develop virtual health in virtual space is also to ensure universal applicability, affordability, accessibility, and of course, unity in the management of the information in virtual spaces. Now, that's a very, very serious challenge. And anybody who knows anything about research over the years will know that it is going to take a lot of work. And that is why it took so long and it has reached this stage. Next slide. Now, anyone who tells you that he has started this research, this kind of research, and that all of this research has come out of his head is talking nonsense. there's an institutional and inspirational historical perspective to this particular project. The first is the Department of Social and Preventive Medicine at the University of the West Indies under the leadership of Sir Kenneth Sander. The fact is that the community health system where we were plunged in and had to work in Hermitage Augustown prevented the conditions for us to understand the relationship between community and health team, the relationship between a university and the development of communities that were adjacent to it. That is the first thing. And the community health aids program and the exposure of us as what you call it, the exposure of young doctors and medical students. And Dr. Arna Brown, who was at that time a student at Immaculate, herself and another colleague, first came to the department and first became inspired by what was done in the department as far as community health is concerned. And she's still there working in the communities. And I'm talking about in the 70s. I'm talking about 40 odd years ago. The next is, of course, a Trenchtown Free Clinic. And what the Trenchtown Free Clinic highlighted was the fact of the poverty that existed in Jamaica at the time. And of course, the discriminatory situation among poor people. And finally, of course, the gaps in people's capacity to develop. Trenchtown Free Clinic gave us some inspiration that it must be corrected. The battery's running low. Check it. Yes. The third perspective that inspired this whole process was the primary healthcare development. And that primary healthcare development came through, of course, the primary healthcare program of the Department of Social and Preventive Medicine and the Government of Jamaica World Bank program. I must say that the World Bank program was part of the inspiration. And of course, that led to the Alma Ata Declaration. Next slide. The UN 1978 Alma Ata Declaration, which of course inspired us all for healthcare for all, primary healthcare for all by the year 2000. By the year 2000, we realized it was a missed opportunity for universal, affordable, and accessible healthcare in developing countries, including Jamaica. And that is what motivated us to look at how we are going to use technology or the advances in technology, information and communication and technology, right, to ensure that we achieve healthcare using what we call telemedicine. So where the use of information and communication technology to improve the lives of the Jamaican people and of course the people of the developing world. And so therefore, that was where the inspiration came from. And that is what drove us. And that is what also created the conditions for members of the Association of General Practitioners in Jamaica, who are now members of the Caribbean College of Family Physicians, who participated in a number of user acceptance tests over the 20-odd year period. And I must say that some of them are here and some of them who know that they also participated. So it was a participatory approach to looking at this particular thing. And I deliberately put this part in here so that it's not seen purely as a one-man endeavor, but a participation of medical students, yes, Students in my School of Public Health, yes. Students in the University of the West Indies, yes. And of course, my colleagues from the Department of Social and Preventive Medicine. A lot of them, Dr. Matthews, Dr. Subri, all of them who participated in some of the user acceptance tests. Next slide. Now, the following basic ethical principles always apply universally to both face-to-face and virtual clinical encounters alike. This is very important. Beneficence, doing good. Non-malfeasance, doing no harm. Fidelity, creating trust. Justice, being fair. Veracity, telling the truth. Confidentiality, protecting or safeguarding participants, identifying information. This is standard practice. And this standard practice of ethics applies both to face-to-face medicine and virtual medicine, medical practice. Next slide. Quickly. The practice of telemedicine must embody all existing principles of the present-day face-to-face practice of medicine. Because you're practicing virtual medicine means that it must embody all existing ethical principles of the present-day face-to-face practice of medicine. In addition, telemedicine's unique feature of the virtualization of the practice of medicine creates new ethical challenges. And these are the ethical challenges which I'm going to deal with. Some of which were discovered during the process of inquiry, of this thing. Next slide. Now, what are some of the presenting new challenges for medical ethics that are different in virtual, in the practice of telemedicine versus face-to-face medicine? There are issues of confidentiality and privacy. Matters related to questions of fairness, accessibility, affordability, remote device application, application of advanced technology, that is machine learning, artificial intelligence, mobile applications, efficiencies and integrity of the telemedicine platform, the online payment system, and of course, protecting the rights of the provider and the patient, patient equality. All right, now, matters related to issues of confidentiality. All right, next slide. The essence of telemedicine is in its virtualization of the practice of medicine. We're going to have to define, not only we have defined telemedicine, but the actual process of the work of telemedicine using the principle of virtualization. We have to define what we mean by virtualization. This process presents new and exciting ethical challenges, which must be resolved to ensure scientific credence, clinical validity, and providers' patient acceptance and confidence. What do we mean by the challenge of virtualization of health and medical data? The process of virtualization by no means exhausts the challenges encountered during the telemedicine practice. Among others, questions of confidentiality and privacy about patient information management looms large. The integrity of the payment system, especially its conformance with the fintech system. What I mean by the fintech system, financial technical system, Bank of Jamaica system, and standards are vitally important to ensure the integrity and protection of the rights, the users, and the providers of telemedicine, the property rights of the users and providers of telemedicine, health and medical services. Next slide. What are the unique challenges of particular concern to practitioners of telemedicine? The practice of telemedicine in a virtual rather than a real space presents the following unique challenges. The first challenge is the result of the digital format of the transmission and management of the information arising from the virtual clinical encounter. Here you are, a doctor, accustomed to seeing a patient face-to-face. You now see him online in a virtual format. Secondly, is the principle of data reflection. Now, you must understand, well, I'll try to see if I can explain what I mean by virtualization and data reflection. If I stand in front of a plain mirror, there is a reflection of my image in that plain mirror. As a matter of fact, the reflection is laterally inverted. My right hand will look like my left hand, and my left hand will look like my right hand. But you will get the exact reflection of the exact image. In other words, the information that you are seeing when you see the patient online or in a telemedicine or in your virtual office is exactly a reflection like you have in that plain mirror. Suppose you didn't have a plain mirror. Suppose, for example, you had a convex lens. That image would be distorted, wouldn't it? So it wouldn't be the real image of the patient, and the data would not be the real data of the patient. It would be a distorted data or a data that is being abstracted, because if you took a picture of that image and use different focal different lens with different focal points, eventually you will get a level of abstraction that you don't even recognize the image. And so the fact is, the management of information arising from the virtual clinical encounter is very important. And therefore you have to define what you mean by the real scientific data that you derive during your virtual clinical encounter. Secondly, is the principle of data reflection, which I define as incremental process of change from real, measurable, quantifiable data to reflected or non-quantifiable data. The process of continuous reflection leads ultimately to an image which may be an abstraction of the real data. This I refer to as a telemedicine data bubble. Now, when I speak of a telemedicine data bubble, a lot of my colleagues laugh. You know why they laugh? Because they already know about a number of data bubbles that you have in the different space, especially in real estate, where you have different contracts, real estate contracts, and different contracts of different types until you virtualize the real property that you have to an extent that nobody will recognize it after a while, and the bubble bursts and a lot of people lose millions of dollars. That can't happen with telemedicine, because telemedicine is saying there's only one reflection, and that is the real reflection. The real possibility of the process of virtualization, creating a telemedicine information data bubble, objectively distorts the scientific validity of the clinical data, and therefore could be challenged as a valid representative of both the content and form of the patient client data, clinical data. Next slide. What is an acceptable image of reality during virtual clinical encounter? Presently, our telemedicine research outcome accepts one mirror image copy only of the real reflected image of an object recorded in the video conferencing of the virtual clinical encounter. This principle is of fundamental importance when building evidence-based clinical databases, utilizing virtual clinical platforms such as telemedicine. The principle of reflection of real objects in a plane mirror represents a genuine representation of only the form of the real object and not its content. Clinical, scientific data must always be based on the principle of being measurable in order for it to be evidence-based and data-driven. Serial reflections of the real object may represent forms of abstraction of the real object and are therefore unacceptable as a true evidence-based representative of the real object. That, my dear colleagues, is what I have found over the past 25 years to be the truth. If anybody who wishes to challenge it, let us challenge it. But I can tell you that it would be a difficult proposition. Next slide. Let's look at artificial intelligence. We did some experiments with about 2,000 cases of artificial intelligence. First, let me define what I mean by artificial intelligence. Artificial intelligence, or AI, uses the performance of a computer as a machine learning device to independently perform functions of the doctor, the dentist, or the veterinarian. The applied research phase of Dr. On Call has tested over 2,000 cases of an artificially intelligent robot, AI DocBot, and we got it from Eastern Europe. It was a nice project. It is a voluntary pre-diagnostic tool. Why does I say pre-diagnostic tool? Let me explain. Which will interact with patients if they so choose while waiting in the doctor's, dentist, veterinarian virtual office or lobby. While the patient is waiting in the doctor's virtual office or lobby, he's approached by the DocBot, and the artificial intelligent doctor will ask the patient while they're waiting a number of questions going through an algorithm. Now, the artificial intelligent DocBot has as its database the massive ICD-10 codes, and they are trained to ask relevant questions and go through that algorithm to determine exactly what is the diagnosis. Now, I said diagnosis, but put that in inverted commas. Because because the AI does not make a diagnosis, we call it a pre-diagnosis. Because once he makes a pre-diagnosis, he has to report to the doctor when the doctor now comes to determine exactly what did the AI say to the patient, etc. Now, the artificial intelligence or the DocBot gets a particular code name, and they call it a GUID. That is a globalized unique ID. Only the doctor knows that globalized unique ID. And so therefore is able to use that information to make a final diagnosis. And so in the final analysis, only the doctor trained in diagnostics, or the dentist trained in diagnostics, or the veterinary practitioner trained in diagnostics is authorized to make such a diagnosis on any telemedicine platform. This artificial intelligence screening uses, of course, ICD-10 code as its database and makes pre-diagnosis during its virtual encounter with the patient. A pre-diagnostic virtual encounter is never complete without the process of validation by the physician or other qualified medical professional. For example, other qualified medical professional who is trained in diagnostic medicine. The DocBot is therefore a patient pre-diagnostic screening tool, identifiable as a globally unique identification of the patient client. All data is in the full ownership and control. I want everybody to understand this. If the data is not under the full control of the clinician, that is the provider of the services, it has no validity. Let me repeat. If the data is not under the control of the clinician who elicited that data with the clinical encounter, it has no validity. Whether this data is enabled by an artificial intelligence bot or even some other algorithm. Now, artificial intelligence screening uses, yes, next slide.
Prof, apologies for the interruption. We are about 8 minutes over time. So please help us catch up some of that time. Thank you so much.
Okay. All right. So the next principle, the principle of capacity and remote access to telemedicine services, right? I'll leave that alone, even though it is a very important principle. Next slide. Aspects of information on voluntariness in telemedicine practice. This is also very important. Information consists of ensuring the subjects are told and they understand the purpose of the virtual clinical encounter and the roles as patient clients. Voluntariness means the subject chooses to be a patient of his own free will and is free to withdraw the service clinically. Paying providers for services is assured prior to the beginning of the clinical encounter. That is part of the standards. Next slide. Telemedicine platform ensuring data validity, scientific credence, and data privacy. All of this, you will see how that is done on the platform. The right to access to all clinical information from the provider. In other words, you, the provider, has the ownership of the data. But the patient or the client has the right of access of all that information. And so you have to provide the information to that person if the person decides it. Next slide, please. The security, of course, we have an elaborate system of security. And that security, of course, is very important. Because if you don't, then you could open yourself to be accountable, what you call the HIPAA access. And you can use your license if you do not ensure confidentiality. Next slide. Next slide. All right, the right of access to registration, right to set. So the doctor now has the right of access to registration, the right to set his fees for service, right to secure payment prior to virtual clinical, the right of all these rights, right, are providers' rights. And there are also rights of the patient. Next slide. Next slide. Patient's rights are the limitation of the most jurisdiction of the world. The right of a patient to healthcare is more often than not an inspiration. The telemedicine platform gives the right of the patient to clinical encounter. Next slide. How is the doctor on call model? Universal access. That is self-evident. Next slide. Use of doctor on call to demonstrate. Next slide. So we have demonstrated the ethical challenges, non-cartelization or no fees splitting. All of these are, in fact, very important ethical challenges that you have to overcome on this platform. Next slide. Now, the One Health platform is the standards that we have developed through the universe, through the Bureau of Standards, ensures that such a platform has space for all providers of healthcare in the public and private domains, and that they must have full access so that we have what is known as One Health platform. And that involves public health inspectors, public health nurses, involved nurses, nursing, involved public, it involves all the professions allied to medicine, together with the doctor, the dentist, vets, etc. And so therefore, all categories of health workers have signed on to these, this platform. And so therefore, it gives them the opportunity not only to practice medicine in normal face-to-face medicine, but also in virtual medicine spaces globally. Next slide. And so therefore, we've come to the One Health platform where practice the principles of professional collegiality. Since everybody practices on the same platform, we are able to communicate and refer and get second opinion right on the same platform, which is part of the WHO mandate. Next slide. These are some of the categories of the allied medical person: medical laboratory technology, speech language occupational therapists. These are also part of the qualification, the qualified persons on the platform. Next slide. Now, the application of telemedicine to non-communicable and communicable disease management. This diagram looks at the whole question of telemedicine and the chronic care Jamaican model. It looks at how do we use the e-health at the community level, working together to deal with the question of the management of chronic care, whether it is communicable or non-communicable disease management. So this diagram here shows the methodology using virtual medical platform, and especially for doctors who are also practicing communities. You can mobilize your churches, you can mobilize your communities, and you can also do massive prevention, anywhere care, which is the mandate of telemedicine. And so you can practice this kind of what you call e-health, using your e-health systems, which you will have as part of your platform. And so therefore, in the interest of time, what I've tried to do is to give you a synopsis of a very complex system, but it's not complex because you can integrate it with your primary care, your secondary care, your remote care. In other words, you can see your patients from your home, from abroad, from anywhere. So that's why we designated the virtual medicine or telemedicine as anywhere care. We have primary care, secondary care, and we have anywhere care. And so therefore, it is part of an integrated system which you can use as a clinical encounter in virtual space. Thank you very much. All right.
Dr. Brown, Morgan, you are muted.
Oh, sorry. Just thanking you again, Professor Davidson, for this talk this morning, in which you have introduced us not only again to the whole idea of One Health and the integration of the health, and of course the whole idea of the DocBot, which is a very important and new idea that a lot of us have to learn about. We know that AI is the in thing and perhaps part of the future. So we'd like to thank you so very, very much for this comprehensive talk on what might be a strong part of the future for us. And so, Prof, thank you so much. At this time, I'd like to introduce our sponsor, Daisy Health. Sam, you could go ahead with their what they have.
Thank you so much, Doc. Daisy Health will be presenting live. Please go ahead.
Good afternoon, everyone. My name is Garth Russell, General Manager for Daisy Health Technology. And it's good that we were placed right after Dr. Davidson's presentation, because Daisy Health Technology is an EMR, electronic medical records system. And so I will now share my screen and present to you what Daisy Health is. So Daisy Health Technology is a secure cloud-based storage platform for medical data. Now, this platform links the patients to the various medical service providers, that is the doctors, the pharmacies, medical labs, and also radiology units. We also have a module for emergency care facilities, the ambulances, and also hospitals. Now, this cloud-based platform allows for flexibility for the physicians, and because we're focusing right now on physicians, in that a physician may access the platform from any device or from any location. As long as the doctor has a compatible device, meaning a laptop, a tablet, it could even be the cellular phone, and they're in a location that gives them internet access. So wired access, Wi-Fi access, or data, which would be through their cell service providers. They will log in with their own private credentials, and they now can access the platform. Daisy Health Technology has encryption protocol of about 2046 bytes. Now, the data is stored on separate servers. And the reason why this is important, because medical data must be properly secured. And we are not saying our system cannot be hacked. What we're saying is that we have put in place a lot of work to ensure that even if someone tries to hack the system, they will have absolutely no access to patient and patient medical records at the same time. So the patient's basic information, name, date of birth, address, email, is stored on one particular server, whereas the medical records are stored on a separate server. And this now prevents the two from coming together. Only at the doctor's office, where the patient gives access, that is by handing in their access card, and the doctor swipes at the office, will the records come together. Access at the doctor's office is role specific, meaning that a doctor sees what a doctor is supposed to see, the nurse sees what the nurse is supposed to see, and the receptionist, and the list goes on. Doctors will use a two-factor authentication system to access the medical records of his or her patient. We're compliant with HIPAA, IAASP Top 10, and we also have ISO credentials. Daisy Health Technology has implemented Health Level 7, that's HL7, and the Fast Healthcare Interoperability Resources, FHIR. So therefore, we say that DAISY has HL7 on file. This means that we can integrate with any other software that also has HL7 FHIR compatibility. And this is necessary for any software being used in the healthcare space for security of health information. We also developed our platform to be GDPR compliant. We do not have GDPR certification because we are not entering in the European market at this time, but the system was developed to be compliant with GDPR. Now, as I said earlier, that it can be accessed, the platform can be accessed by a device that is compatible, meaning that it's either running on Windows or a Mac platform, or, sorry, not or, but and the individual is using the Chrome, that's Google Chrome or Microsoft Edge, or sorry, Mozilla Firefox browsers. Now, key features, and let me just go through this very quickly. The system, it's very user-friendly, and therefore any physician who use a system will find that it's easy to manipulate, to maneuver through the whole process of administering care to their patients, from the receptionist to the nurse to the doctors, everything. It's very easy to use. There is an appointment scheduling module where patients can be scheduled for an appointment by the nurse or the doctor, or the patient through the patient app, which can be found on the Google Play Store or the Apple App Store. They can apply, schedule an appointment for the doctor once the doctor enters their schedule. Doctors can access all the medical records for their patients, again, through a very user-friendly system. The encounter is quite efficient, and therefore doctors can work through the vitals, general history, presenting history, examination, assessment. There's also a body chart that's very interactive, and the prescription referral module is there so that doctors can prescribe for drugs or make referrals for lab tests or imaging, or they can refer the patient to another doctor. Clicking through using all the check boxes and the drop-down boxes, it's easy for doctors to use. If there is need for more information, they can add the comment by typing. Also, doctors can write as they want to, and scan and upload into the system if needs be. We use the ICD-10 codes, and it's linked with a very large platform with all the ICD codes and the CPT codes. So this section for assessment, again, it's very, very intuitive for physicians. And as I mentioned before, prescriptions can be created for your patients. Can also create a referral for lab tests. We have a simple or basic billing feature. It's not an accounting system. However, we allow them to doctors to take records. And coming down to the end, anyone who wants a demo can always request a demo from us. Our business development executives will go right across the island or out of country to do a demo, or it can be done virtually. And so that's our contact information, and I will place in the chat where you can go to request that demo. Thank you very much for the opportunity to make this presentation.
Thank you,
Mr. Russell.
Dr. Russell. We're moving on now quickly, and
actually, Dr. Morgan, apologies. Lisa and McGill, PA Benjamin. is to
Yes.
go now as well. So we'll hand over to Lisa Ann from PA Benjamin. Hi, Lisa Ann.
Hi, good afternoon.
Afternoon.
Let me share my screen. Share. Good afternoon, everyone. My name is Lisa Ann McGill, and I'm a medical representative at Facey Commodity Limited. And today I'll be representing the Benjamin's Pharmaceutical Division. So today our focus will be on the relief line. As you know, the flu, cough, and cold season is quickly approaching. So you'll find that a lot more patients are coming to you seeking a relief for their symptoms. Now, our relief line consists of products for a variety of symptoms. Say, for example, your patient has a persistent cough or a bad cold. We have the relief cough and cold just for that. It has ammonium chloride, chlorpheniramine, pseudoephedrine, and sodium citrate. So all of this combines help to relieve cough, nasal congestion, sneezing, itchy, and watery eyes. But let's say that they have the flu and they're looking for a fast, effective relief without taking numerous tablets. The relief flu multi-symptom is perfect because not only does it has the acetaminophen, chlorpheniramine, pseudoephedrine, and guaifenesin, but it's also a liquid. So you know that it will absorb quickly in the body for that quick relief, because no one wants to have the flu for weeks on end and miss out on their daily life. So this product will be perfect for that. Now, we did not forget about persons who have really bad sinus symptoms, such as nasal congestion, nasal and head congestion, facial pressure, and so on. Because sinusitis can really dampen anyone's day. I mean, I should know because I have it as well. But the best relief for that is the relief sinus, because not only does it has a decongestant, which is a pseudoephedrine, it also has an antihistamine, which is a chlorpheniramine, and acetaminophen as well. Now, the beauty about all three products is that it is family friendly. So children starting from the age of 1 through to adults can take it. And it's also very affordable. So imagine a product that is family friendly, very effective, and affordable. I mean, what more could you want in a product, right? And we also have our relief expectorant, which is safe for diabetics and hypertensive, because they too need a relief from coughs and cold. It has a diphenhydramine, ammonium chloride, and sodium citrate. And it also tastes great because it comes in 2 additional flavors, such as cherry and grape. And it's also sugar-free and alcohol-free. In addition to that, we also have the relief elixir. And this is our only product with solely diphenhydramine. It is perfect for allergies and runny nose. And it's also sugar-free and alcohol-free and perfect for the entire family. Now, for children with immunization, pain, toothaches, muscle aches, and etc., we have the children's relief fever and pain with acetaminophen. And as you know, children are picky when it comes on to taste, so they'll appreciate the taste of this product as it comes in cherry and grape, and it is safe for children 6 months and over. So doctors, relief is what your patients need. So this product is easy to remember. So when your patients have the flu, sinus, cough, and cold, write relief, because I mean, relief is all that you need. But now, what if I told you that we have a product that works faster than a hot cup of tea? Because you know, as Jamaicans, we love tea. We drink it morning, noon, and night for gas and indigestion. So let me introduce you to the Benjamin's Anti-Acid Anti-Gas, which contains aluminum hydroxide, magnesium hydroxide, and simethicone. And this product helps to bring fast relief from stomach gas, heartburn, indigestion, and hyperacidity. And not only that, this product also tastes great because it's peppermint flavored, and it's also very affordable. So again, when your patients are seeking that quick relief, don't forget to write the Benjamin's Anti-Acid Anti-Gas and the relief line, because again, all you need is relief. Thank you so much for your time and your attention. Please do enjoy the rest of your day. If you have any questions, you can place this in the chat. Thank you.
And thank you too. I'd just like to take this quick moment to thank both Dr. Garth Russell and Miss McGill from Daisy and from P.A. Benjamin for their support. We couldn't be doing this presentation, this conference without you. So thank you very, very much. And I'd like to take this opportunity now to move on. It is my privilege to introduce to you Dr. Karen Carpenter. Dr. Carpenter, you are here with us. Thank you. Dr. Carpenter is a well-known and popular speaker on gender issues and is our guest today. She needs little introduction. She's a senior lecturer and head of the Institute for Gender and Development Studies at the University West Indies Mona campus. And her area of specialization includes gender and sexuality, interpersonal dynamics, diversity and relational challenges. She's a psychologist and a licensed counseling psychologist here in Jamaica. She is a Florida-based certified clinical sexologist and the editor of several articles and author of Love and Sex and the Basic Questioning Caribbean Jewish Identity, a number of articles and books. And her research interests includes gender and human sexuality, psycholinguistics, and phenomenology. I have to say this, phenomenology. I'm going to ask you to tell me what that is, Dr. Carpenter. She is the director for the Caribbean Sexuality Research Group for the Free Sexology Clinic at the University Hospital of the West Indies. And she's also the host of Love and Sex on Facebook. So over to you, Dr. Carpenter, and you explain a little bit about, you're going to present today on having given the height, gender-based violence, ethical considerations. And she'll tell us a little bit about some of those words that we have in your time, Doc.
Thank you for that introduction. And phenomenology or phenomenological studies are person-centered studies that look at the subjective experiences of individuals and through that bring them together to form notions on and insights about how a group or specific population might experience a phenomena, hence the word phenomenology. So let's look at the phenomenology of gender-based violence, because it is indeed an individual experience. And by collecting the individual experiences that we hear about here in Jamaica and elsewhere, we come to some sort of understanding about how this is lived, how it is treated, and hopefully how we can prevent it. I want to give a nod first and foremost to Ruth Bader Ginsburg, the late Ruth Bader Ginsburg, phenomenal woman, phenomenal contributor to some of the rights that we take for granted today, both for men and for women, and the rights that enshrine economic, social, and political equality among the sexes. I mention Ruth Bader Ginsburg because, as they say sometimes, no good deed goes unpunished. Ruth Bader Ginsburg, in winning her cases at the level of the Supreme Court, ultimately, that enshrined the rights of both men and women to access to things like childcare benefits and being able to stay home as a man and take care of your mother who's ailing. In winning those rights, part of what she did, which you can see in the documentary On the Basis of Sex, very important documentary for us all to watch, part of what she did is that instead of using the word sex in these many, many, many dissensions that she wrote and many, many papers that were submitted and presented to various levels of the judiciary system in the United States. She exchanged the word sex for the word gender because her audience was primarily men and because she felt it would distract them from the issue of human rights were she to present these documents with the word sex. And so she is in part responsible for the reason that we continue to confuse the notions of sex and gender. And so I'm hoping that at least minutely, we'll have a better appreciation of how they're different. Her original document actually says on the basis of sex, not on the basis of gender, as it relates to discrimination. So I want to give a nod to the amazing work that she's done in providing for all of us. I also want to look at what we consider to be universal principles of gender and health. And I'm looking to the World Health Organization primarily for those definitions. And we can see that gender interacts with, but is different from sex. When we speak of sex, we're speaking about biological differences. We're speaking about physiological characteristics of males, females, and intersex persons. Things such as chromosomes, hormones, reproductive organs. Gender and sex are certainly related, particularly culturally, but they act out and play out differently from gender identity, and they play out differently depending on the culture that you find yourself in. Gender-based violence, to speak more specifically about the topic we're looking at today, is violence committed against a person because of his or her sex or gender. It's forcing another person to do something against their will through violence, coercion, threats, deception, cultural expectations, or economic means. And I would add to that things such as neglect, because gender-based violence can certainly be enforced through coercion, through neglect, through withdrawing of finances, through deprivation. Although the majority of survivors of GBV, as we're going to call it throughout, are girls and women, LGBTIQ plus boys and men can also be targeted through GBV. So it's our perception of the vulnerability of the other gender that allows us to be coercive in the interaction that creates gender-based violence. We're specifically interested today in violence against women, particularly intimate partner violence, IPV, and sexual violence, SV, is a major public health and clinical problem. And it is a violation of women's human rights. It's rooted in and perpetuated because the gender inequalities persist and women and girls find themselves at a disadvantage within societies. Our overview, so that we can be guided, as to where we are in the presentation. I was asked to address two questions, and one of them is, should doctors be activists? And the second, what ethical conditions must be addressed in the management of gender-based violence? And I've also chosen to address the duty to report, the notion of permissions, and resources and approaches. And I hope you'll find them helpful. We reference a women's health survey quite a bit, and hopefully we'll have a new one to reference very soon. This is a 2016 survey published between 2017 and 2018, but the data was collected in 2016 to 2017. And what we do discover from the Women's Health Survey, which we quote quite a lot in GBV, is that more than 1 in every 4 women in Jamaica has experienced IPV, or intimate partner physical and sexual violence. So if you're in a room with 10 women, 1 in every 4 of those women has experienced physical or sexual violence at the hands of a partner. The first comprehensive Jamaican National Survey on gender-based violence revealed a prevalence of 27.8, which is 28% really, of women who are affected by one of those types of violence. And additionally, we know that about a quarter, 25% of women in Jamaica has experienced physical violence without sexual violence. So when we take physical violence alone, We know that 1/4 of Jamaican women have experienced physical violence at the hands of a partner, and usually a male partner, during their lifetime. This is a very alarming statistic. So again, if you look around a room, if you look around a bus stop, if you look around a classroom, if you look around the streets that you're walking on, and if you count 4 women, one of them is likely to have experienced some form of physical violence from a male partner. So the question that was posed was, should doctors be activists? Naturally, that's a question that doctors will have to answer individually for themselves, quite phenomenologically, actually. And I want to raise some of the issues that we think of when we think of doctors as activists. Activists need to be change agents. So if you're an activist, you want to change something within the society. You want to work to educate, organize, and involve the general public. So for instance, Dr. Davidson's presentation on AI and the use of AI and the medical robots, etc., online medical information, shared files, and integrated practice across these platforms is already in place in some countries, and it's certainly one of those ways that we can be an activist for change, how we can educate the population about their access to information, organize that information, and involve the general public in knowing that if you have a device that can access the internet, you can certainly be a part of your own medical care. So activists actively oppose present policies and seek positive and constructive solutions. To be an activist, you must be trying to change something. You can't be an armchair activist. You must be seeking the public's involvement in those changes. And I like what we're hearing about the e-medicine, which is already being practiced in the UK and Canada, because it gives the patient the kind of autonomy that we're going to talk about. It gives the patient that involvement in their own care and that responsibility for ensuring that their care is well managed. Are there particular issues in your fields as doctors who are attending today that you are passionate about defending? This is a conscience vote. You would have to consider what it is that keeps you up at night and what it is that you see as an injustice during daily practice that you'd like to address. And will it, in fact, benefit the larger public? And that becomes the point of activism. Health activism, as it's sometimes called health activism, it's sometimes called medical activism, is a kind of advocacy, obviously, that narrows down the field to direct service to the individual or family, as well as activities that promote health and access to healthcare in communities and the larger public. So once you're increasing the access of the general public and individuals and families in their ability to access healthcare, that's a great form of health activism. It's also an action that's taken on behalf of a cause, an action that goes beyond what is conventional or routine in society. And of course, I recognize many faces here that I know have been very active activists within various healthcare realms, including HIV prevention and control, and who've been challenged. You will not go unchallenged if you're an activist. You will face challenges. And I think it's our jobs as activists to educate respectfully and to recognize that while we do want to share what we believe to be the right and conscience-driven approach, that others have a right to their objections as well. We have to be very mindful of that. So it involves a challenge to the existing order whenever it is perceived to lead to a social injustice or inequality. So health activism is a form of social justice, assuring social justice. It is aimed at increasing justice and decreasing inequality in the society. Because of this, medical and health activism tends to look at the more vulnerable communities within the society and tries to ensure increased access for those groups. So LGBTQIA or LGBTQA+ access to care has been a very important part of medical and health activism. PLHIV access to care has also been a very important, and I think we've been extremely successful at changing attitudes and changing approaches, not just of medical professionals, but also the wider society about what it means to be a PLHIV. I think Jamaica has been extremely successful at that acceptance of the fact that this person has a right to prolonged life, prolonged care, and equal treatment. We have a lot of work to do on adolescent access to sexual health care, but I see changes already. And perhaps the longer you live, the more changes you see, right? But I do see some positive changes in terms of adolescent access to sexual health care. And we have to now increase adolescent information and knowledge. And it can't start at adolescence if we want young people to make good choices. Another area of concern for activism, for medical and health activists, could be, and it's not restricted to the ones I presented here, female access to autonomous reproductive health care, such as contraceptives, voluntary sterilization, and abortion. And these are issues that are very topical right now. And it makes us have to think back to whether or not our decisions about our own personal health care are decisions that we can, in good conscience, place on others. So these are ethical dilemmas that don't have easy answers, but they certainly should be debated and should be considered. I want to take us back to a moment in time, which may now seem very, very removed from our present day experience. And that was the questioning of Brett Kavanaugh by the now Vice President of the United States when he was going to be placed in office. So I'm going to see if our link works. Tell me if you're seeing the link.
Any laws that give?
I'll ask Sam to tell me if he's seeing the link. Sam, are you seeing the link?
We're seeing the link.
You're seeing the video.
The video is not playing yet.
Okay.
Can you think of any laws that give government power to make decisions about the male body?
I'm happy to answer a more specific question.
Male versus female.
There are medical procedures.
Okay. That the government has the power to make a decision about a man's body.
I thought you were asking about medical procedures that are unique to men.
I'll repeat the question. Can you think of any laws that give the government the power to make decisions about the male body?
I'm not thinking of any right now, Senator.
Okay. And I chose to share that specific clip because it's quite neat. It's to the point. It tells you exactly what the issue is. And the issue there is certainly whether or not governments should have the right to make decisions about male bodies or female bodies or only female bodies and not male bodies. Why not laws that prevent further unwanted pregnancies, such as laws that help men to choose vasectomies or doctors to advise men to have vasectomies when the woman might not want to use contraceptives? We have no such laws on the books. So these are ethical questions that relate to healthcare, not just in physical healthcare, but also in the psychological and psychosocial issues that face people. If we look at our local context, we can easily pick out one of many, because he's not the only one, but it was very neat and easy just to find information on Michael Abrams. Michael Abrams has been a local medical activist. He has campaigned consistently for both the understanding of, the comprehension of, and the questioning of the laws that we have that govern a woman's body. Others of us may choose to be an activist on other health issues and other medical issues. This is just one such example. And I think it's always good to bring it down to the local context. So the second question was, what ethical conditions must be addressed in the management of gender-based violence? And one of the big questions that I think Dr. Alverston Bailey raised very, very early in the conference is the issue of the duty to report. What is your duty to report? What does the law say about your duty to report? And what does the medical board say about your duty to report? What guides your disclosure? And are you free to disclose about someone's likely harm or harm that has already been committed? And we have to be conversant with the law to understand that. Within the practice of psychology, we certainly have a duty to report certain types of criminal activity. If it's a crime, we have a duty to report it. We do not report it without informing the client. However, we don't go behind the client's back and inform it. And we do caution clients when we are listening to the issues that they raise, that we do in fact have a duty of reporting. So the language that has been used over time has been rather mild, but I believe the language is getting more strong as we go along, as opposed to practitioners being encouraged to report it. I think the language is now becoming mandatory. And you will see as rights violations persist, that the language will become much more strident about the neglect that we perform or we engage in when we don't report. And we're particularly concerned, of course, about minors. Yes, this is an important and serious issue for us in Jamaica. So what is your duty of reporting? Then we need to think about things like permissions. Do you get consent? Do you get assent? Do you release information to a third or fourth party for other kinds of care? Again, we have to ensure that we have the buy-in of the patient or client. We must be clear that while we can provide confidentiality, we rarely can provide anonymity, especially if we're in the public health system. You're taking down a record, you're writing down details of the presenting complaint. It's going to be very difficult to say to this person, oh, I'm going to erase your name and put somebody else's name. That's not going to happen. So we have to be clear. We also have to think about how we minimize risk, both to ourselves, certainly in terms of liabilities, but more importantly, to the patient or client and those who live in the same domicile with a patient or client, because the repercussions of gender-based violence don't only accrue to the victim or survivor, they often accrue to children of the victim or survivor or friends and relatives who support the reporting. So we have to be very cautious in what we do. Some ethical things, we said permissions, consent, assent, release. Informed consent, not just at the beginning, but at all stages. And this is something that I think doctors take for granted. I certainly myself experience that when I go to some medical facilities, the more well-trained, modern private doctors tend to be a lot more informed about patient rights. But we do still have doctors who play the role of Dr. Parson, psychologist, family friend. They want to play all the roles at the same time. That's not really, I think, our job. So we have to keep asking consent for each of the procedures that we would like to engage in on behalf of and for the benefit of the client or patient. The principle of respect, I think, is what is missing in many instances. We tend to paternalize medical care or maternalize it if it's a woman, and we tend to speak down to patients and clients, thinking that because they don't have the specific expertise, they're not going to understand what we're saying and therefore aren't in a position to make decisions. And I think that shows an extreme lack of respect. If we respect our patients and clients, and we respect their opinions, and we respect their time, and we respect the fact that they have an existence outside of those few minutes that you're spending with them, and that may impact their lives more than the few minutes that they've spent with you. So that boils down to respect for autonomy and protection of persons who may be vulnerable when they leave your office. I think often it's not recognized that perpetrators can and will bring the victim or survivor to your office. They often accompany the victim or survivor because that is a form of surveillance. And they may often want to be in the room with the victim or survivor to ensure that they don't disclose anything that they shouldn't. In recent training that we did with the Faculty of Medical Science, one of the things that we encourage first responders to do in the case of nurses is to ask a general question. You don't have to ask pointed questions. We're not expecting anyone to say, oh, are you being beaten? But you can ask generalized questions, oblique questions, such as, how are things at home? How is the family? If the person has trust in you, and I think it was Professor Figueroa that mentioned trust, if they have the trust in you and they feel safe in the environment that you've provided, they might disclose something that would assist you in helping them. So these kinds of protections of vulnerable persons are usually addressed by individual informed consent procedures and at each stage. I want to emphasize the importance of your security guards, your front of office personnel, the receptionist, the receiving nurse, all of those persons who are involved in triage. If they are not informed, educated, trained in GBV first responder care, it's going to be very difficult for you to get the trust of the individual who's sitting in front of you. That individual will be re-traumatized each time they encounter a hostile environment. So I think it's quite important when you're providing this kind of sensitive care to inform the security guards, the front desk people, the nurse who's going to take the weight and blood pressure, etc., about what your approach is to GBV and whether or not you're GBV receptive and you want them to be aware of these things. So the last point on that was, what is a doctor's stance? If your stance is that you are zero tolerant of gender-based violence, if your stance is that you're an activist, a medical activist, that's going to determine the kind of care that you provide. There's legislation and supporting framework in Jamaica for a number of these things, and I'm hoping, yes, that we have a live link, which takes us right there. And you will notice that this document is in places, because it's 2020, yes, is somewhat outdated in some places, but overall it gives good guidance as to what we are experiencing. And if you notice that the number of cases of sexual violence, number of cases of sexual harassment, number of cases of people trafficking, yes. And I want us to look at existing violence protection mechanisms, shelters, restraining measures, occupation order, protection order. These are all things that if we know about them, we can give good advice to clients and patients as to how they might protect themselves. We can't force them to do anything, but we can certainly give them more information. And we have to be judicious in how we give the information as well. We have to be careful not to alert the perpetrator by insisting on them taking things like brochures, which might not be what they want to take out of your office, particularly if a perpetrator is waiting on them outside. Do we have compulsory notification? As of 2020, we didn't. But as I say, legislation is changing and being updated, as well as on this document, it also asks about whether or not the legislation considers transgender, whether or not the legislation is looking at sexual harassment. At the time in 2020, it had not. But in 2021, I believe it was July 13th, 2021, that changed dramatically because we put into law the Sexual Harassment Act, which places a legal obligation on institutions, on workplaces to ensure that their workers are protected. So I've put the links in so that you can follow the trail and look at the more updated information as it comes out. Integrated practice in GBV care. We speak a lot in psychology about integrated practice because we understand that it takes a village. We understand that the care that we might provide may not be the full range of care that the individual needs. So, excuse me, if we notice that a patient or client is showing signs of GBV, gender-based violence, or indeed has said to us that they're being battered, we have to think about all of the steps that go into the care of this person. As we said, no compulsory notification as of 2020, but that is changing. Yes? Doctors and other healthcare professionals, however, are encouraged as good practice to report IPV cases to the police. My caution would be you're encouraged to do so along with informing the patient or client that this is a step that they could take. You are encouraged to provide access to psychosocial support. And I would say provide it as early as possible, as discreetly as possible, using a trauma-informed approach. Recognizing that if the person is sitting in front of you with bruises and shows signs of battering or broken arms, ribs, etc., that this person may be very much in fear of their life or further harm. So provide this information discreetly, recognizing that probing excessively in the doctor's office may not be the best thing for the trauma that the person has experienced. People don't want to be telling their stories over and over. Be mindful that repeated retelling can be triggering, is what I'm saying. However, the term PTSD is only used 6 months or later after the incident, because PTSD involves flashbacks, recall that is involuntary. And here's a DSM caution for PTSD. Of course, it's not the full criteria. It's a delayed specification. Full diagnostic criteria not met until at least 6 months after the trauma or traumas, although onset of symptoms may occur immediately. So you could find a person flinching immediately. You could find them very guarded. You could find them very vigilant. You could find them very anxious. They could sink into depression, some of the things that go with GBV. And also we have to determine what risk factors exist for the patient at home and in the community. As you know from the ecological model, the social ecological model of violence, that if the society, community, lane that they live on, or district that they live in supports the idea of gender-based violence, it's going to be very difficult for that person to report. And they will have to find a number of ruses to get any kind of assistance. Be very mindful of that your circumstances and theirs are different. 2 cases that we can briefly look at. Mrs. Brown, and these are actual cases, 38 years old, married. She was married for 12 years with 2 children. Yes.
Thanking you, asking you to synopsisize as best possible, please.
This is the penultimate slide.
Thank you very much.
Yes. What I received was a call from the chaplain at KPH. Photographs were taken, hospital record reports to GBV. She came in for a therapy session. She was encouraged to make a police report, and she was encouraged to change her domicile, which she already had wanted to do. The husband's response is what was curious. Not only had he taken her to KPH, having battered her from head to toe, but he stood guard at KPH for several days. And the chaplain called, very nervous, that this person could actually choose to harm the staff or harm her. And then he brought her for her therapy session. And then he came in afterwards unannounced to have a session of his own. So people's reactions might surprise you sometimes. Another case, Ms. Smith, 35 years old, dating, has a 15-year-old son from a previous relationship. We receive a call from her sister at University Hospital of the West Indies, ANE. No photographs were taken. Hospital record does not report the GBV because she did not report it as GBV. She did not come in for a therapy session because she refused to report it. No police report was made, no change of domicile, and the response of the ex and the family was to cover up the incident, although she too was beaten from head to toe. We cannot provide help for people who don't want help. We can only encourage them to remain in touch. And as psychologists say, my door is always open. And if you can give them that assurance that you will assist when they're ready, they may actually come back. I've had that happen several times. So the resources for your own use, you'll see that is a toll-free line that the Bureau of Gender Affairs provides. Your Medical Council of Jamaica Guide to Ethical Practice, it's well worth all our time to reread that. It has much of what we've said today. There are justice services for victims that are available. There's a National Strategic Action Plan. There's Women's Inc. that provides shelter, E4Life that provides shelter, Rise Life Management that provides counseling services. And like I say, don't try to be a jack of all trades. Do use an integrated approach to helping to stem this violence against women. Thank you.
And we thank you too, Dr. Carpenter, for this presentation you've made, which is just opening up doors and giving us the sort of the tip of the iceberg of what is really happening here in Jamaica. We hope to hear more from you again soon. Thank you very, very much.
Thank you.
It is now it's now just for me to ask MedImpex Jamaica to come online and do their presentation, one of our sponsors. Thank you.
Thank you so much. MedImpex has prepared a recording. However, we do have a representative here with us, Paulette Bedward. Paulette, would you like to say something before or after the video? All right, so let's have Paulette talk after the video. Let's go into it now.
Hi, good day everyone. My name is Paulette Bedward, medical representative here at MedImpex Jamaica Limited. And today I'll be spotlighting Amlator, which is the latest addition to the MedImpex portfolio. Amlator contains amlodipine and atorvastatin, and the drug tagline is flexibility for better risk reduction. Amlator is our fixed dose combination of amlodipine, which is our calcium channel blocker, and atorvastatin, which is our statin, our HMG-CoA reductase inhibitor. Amlator comes as 3 strengths, which is our fixed dose combinations of 510, 520, and 1020. And this shows a picture of the boxes that they are available as. It's 30 tablets per box. Why Amlator? 1, because of its therapeutic benefits, the adherence component, and also the pleiotropic effects. Therapeutic benefits. Dr. Eddie Keys conducted a study titled The Success of Fixed Combined Amlodipine Atorvastatin Amlator Therapy in Patients with Hypertension and Dyslipidemia. And the goal of the study was to assess optimal target blood pressure and lipid profile. The study consisted of 2,606 patients, age ranging between 18 to 75 years old. Patients who participated in the study had to have the combined presence of high blood pressure and dyslipidemia. Blood pressure values had to be above 150/90, and importantly, they did not reach target value of 140/90 with previous therapy. Total cholesterol levels had to be greater than 5 millimoles per liter, LDL greater than 3 millimoles per liter, and triglyceride levels greater than 1.7 millimoles per liter. The study lasted approximately 2 years, with participants being observed over 1 month, 3 months, 6 months, and a year interval. Now let's look at these results. After month 1 of treatment, 42% of patients had achieved their target blood pressure of less than 140/90. After month 3, 73% of patients had achieved their optimal target levels of less than 140/90. And after month 6, a whopping 87% of patients achieved their target blood pressure reading of less than 140/90. So overall, there was a 23.1 millimeters mercury reduction in systolic blood pressure and 10.4 reduction for the diastolic blood pressure. When it comes to the lipid levels, after month 1, similar results were obtained. 42% of patients had achieved their target of less than 4.5 millimoles per liter in total cholesterol and less than 2.5 millimoles per liter in LDL. After month 3, 77% of patients had obtained these results, and after month 6, 76% of patients had achieved their targets. So in concluding, antihypertensive and anti-lipid therapy with a fixed combination of amlodipine and atorvastatin can be used safely with a high level of success in high-risk antihypertensive patients with dyslipidemia. And that's the conclusion from the study. Adherence. Complexity of therapy is a primary deterrent of treatment effectiveness. Fixed dose single pill therapy with Amlator provides several options that help achieve improved patient adherence. The use of fixed dose combination therapy will reduce the number of tablets, resulting in better compliance with treatment recommendation. And this graph shows that the adherence with both a statin and a calcium channel blocker is greater compared to the single pills only. And remember, drugs don't work in patients who don't take them. Amlator has pleiotropic effects. And the pleiotropic effects of a drug are the actions other than those for which the drug was specifically developed. And these effects may be related or unrelated to the primary mechanism of action of the drug, and they're usually unanticipated. The pleiotropic effects of Amlator, there is increased presence of nitric oxide, reduction in insulin resistance, reduction in the inflammatory parameters. There's improved presence of the tissue plasminogen activator as well as its enzymes, improved arterial wall compliance of both the small and large blood vessels, and also a reduction in the left ventricular mass. So Amlator, amlodipine plus atorvastatin gives a synergistic effect. Patients suited for Amlator: those who are starting therapy, substitution therapy in patients on monotherapy, switch therapy in patients treated with similar drug class, additional therapy in patients already on similar drug class. And in the Gemini study, patients with hypertension and coexisting dyslipidemia are treated with fixed combination as starting therapy and also as optimized current therapy. What also makes Amlator desirable is that there's no particular time of administration. It can be given any time throughout the day. It can be given morning, noon, or evening. Cost. We know cost is a major factor. Prices are very affordable for each of the strengths. Cost to the patient after NHF subsidy is less than $200 for a month's supply. And just a few reminders: Amlator, the single pill therapy, provides flexible dosages that help achieve improved patient adherence. Amlator is the powerful combination of amlodipine and atorvastatin that provides 3 different strengths to allow adaptable treatment. Amlator, proven efficacy in primary prevention of cardiovascular events. And Amlator is well-tolerated fixed combination therapy that provides long-term CV risk reduction. And thank you very much for having MedImpex this afternoon, and remember to prescribe Amlator.
We thank you very much, MedImpex. Thank you so very much for that wonderful new drug for helping our patients survive healthy. And we'd like to move on to our final speaker for the second session. And this will be Professor Helen Trotman. I think it's Trotman-Edwards. Just checking that she's here with us, Professor Trotman-Edwards.
Yes, I am.
Wonderful. So Professor Helen Trotman, she is professor in the Department of Child and Adolescent Health at the University of the West Indies, Faculty of Medical Sciences, Mona, Jamaica. She is also a consultant neonatologist at the University Hospital of the West Indies. She does clinical research in the field of pediatrics and neonatology and she holds an MBBS degree, a diploma in child health, a Doctor of Medicine degree in pediatrics, and a Master's of Public Health from the University of the West Indies. She also has a Master of Science in Bioethics from Clarkson University and has pursued her fellowship in perinatal and neonatal medicine at the Oregon Health Science University. She's currently chair of the Mona Campus Research Ethics Committee, and she will speak with us this afternoon on ethical conflicts in patient-centered care. So without any further ado, please welcome Professor Helen Trotman-Edwards. Over to you, Prof. Please unmute.
Hi, good afternoon. I'd like to take this opportunity. Are you seeing my screen?
Yes.
Yes, we're seeing it.
I can't, oh boy. Okay, hold a minute. I cannot get it.
In the presenter view, you probably have to end the presentation and
Oh,
start.
right.
Or you can click on the share button and at the top go to advanced and click on portion of screen.
Boy.
While Prof is working that out, I want to thank Prof and all our presenters so far. Ladies and gentlemen, you do not have to request CMEs. CMEs for this event, thanks to our sponsors and the organizers who worked tirelessly to put on such an awesome day for you, will be sent to you automatically once you've logged in. All right, so please, you don't need to request CMEs. Prof, over to you. We can see your
Yeah, I know. What happens is that there is at the bottom of my, okay. Oh boy.
Want to detail it to me and see if I can help?
Okay.
Perfect.
Great. All right. So good afternoon. I'd like to take this opportunity to thank the organizers of this conference for inviting me to speak this afternoon. And as previously said, I'm going to do ethical conflicts in patient-centered care. What we'll do, I'll start off by going through the principles of clinical ethics, a lot of which has been done already, but we will go through. I will go through patient-centered care, and then I would go through two areas in where we can see conflict. One of those would be the shared decision-making, and the other is in the patient-healthcare professional relationship that exists within patient-centered care. So principles of ethics, really we have three major headings. And so there is respect for persons. And under that is that persons should be treated as an autonomous being, right? So we believe that persons are autonomous, which means they are capable of deliberation about their personal goals and then acting under direction of such deliberation. We do recognize that the person must have the capacity or the competence to do that. And we also, under respect for persons, we recognize that persons with diminished autonomy must also be protected. We also recognize that throughout the life cycle, your autonomy may change. For instance, neonates, babies, children, they are diminished autonomy, and so they require protection. But as they grow and their autonomy grows, when they become an adult, they can make their own decisions. So we recognize, one, that persons are autonomous, and we also recognize that persons with diminished autonomy must be protected. Now, coming out of that respect for persons is the whole concept of informed consent. And I would like to say that informed consent is a process. It's not a one-off deal, it's a process. And during this process, autonomous persons are presented with information. So there's full disclosure, there's information, right? there also has to be comprehension. So they are given the information, but they have the ability to comprehend. And then whatever decision they are made is done so voluntarily. And also under respect for persons, there's truthfulness, there's confidentiality. Doctors, must keep information confidential. And there's also that trust between a healthcare provider and the patients. So that's the first principle, respect for persons. Then we have beneficence or non-maleficence, right? So healthcare providers are called on to act in the best interest of the patient. We also must, in doing so, we must inflict no harm on the patient. And so this brings us to that risk-benefit assessment for all intervention or treatments, right? Where what we opt to do or what we hope to do is maximize benefits and diminish harms. And what this will result in is the best course of action for the patient. And then the third principle is that of justice. The one that really applies to clinical ethics is really what we call just distributive justice, right? And we look at fair, equal, appropriate distribution of healthcare resources. Now, there are many different ways that people will determine this distribution, right? So there could be equal share for everyone, or it could be based on according to need. It could be based according to effort, according to contribution. There are many different ways, and that is really set by the social sort of environment that we are in. And the second part of that distributive justice is that what is being done for one group should not adversely affect other groups. So, from a long time ago, Hippocrates said, it is important to know what sort of person has a disease than to know, it is more important to know what sort of person has a disease than to know what sort of disease a person has. So that brings us to patient-centered care. And there are many different, if you're looking at many different definitions, about it, I'm going to use the one from the Institute of Medicine, which says that patient-centered care is providing care that is respectful of and responsive to individual patient preferences, needs, and values, and ensuring that the patient values guides all our clinical decisions. So the basis under patient-centered care, the basis of our healthcare decisions are based on the specific health needs of the person we are dealing with, and also the desired health outcomes, which is influenced by the person's preferences, needs, values. So we are not only, so coming out of that, there is a partnership between the patients and the healthcare professionals. So we are working in partnership for the benefit of the patient. So healthcare professionals in this context treat patients from a holistic perspective. Now we recognize that this is what we are supposed to be doing anyway. And it may not be unique to patient-centered care, but what patient-centered care is saying now, we are going to be intentional about this. So we are not only looking at the clinical perspective, which sometimes we get lost in, but we're also looking at that emotional, mental, spiritual, social, financial. We are looking at the patient in a holistic way. And so it is an active patient-centered care, is an active collaboration between healthcare provider, healthcare professional, and the patient, in which there is shared decision-making in order to design and manage a customized, comprehensive care plan. And it takes into account the patient and family preferences, values, cultural traditions, socioeconomic conditions. All of these are respected in when we are developing that plan. Now I have put here for you, PICA's 8 principles of patient-centered care. Now, as I said, there are many different definitions. I am just using this. This actually was devised by a set of researchers coming out of Harvard Medical School. They were actually doing research for the PICA's Institute. And they did focus groups where they spoke to patients, family members, physicians, other hospital workers, and they also did a literature review. And they came up with 7 principles, and then they added the 8th. And so this is respect for patients' preferences, coordination and integration of care, information and education, physical comfort, which sometimes that's not something we tend to look at, emotional support, involvement of family and friends, continuity and transition, and that 8th one that was added, access to care. So there are many benefits of patient-centered care. So some of them are improved patient satisfaction, because as was previously said, most people are interested in their health and in being a participant in that healthcare process. So the improved satisfaction came from the inclusion in decision-making processes that affected their health and well-being. There was enhanced self-efficacy. They got the impression, I can, be master of my health. And there was also this feeling of responsibility for their own health. There's also enhanced reputation of the healthcare professionals, because in the patient-centered model, that relationship, and we'll come to it, the relationship between the healthcare professional and the patient, it's a more intimate relationship than we currently have. And so the patient felt that the healthcare professional cared about what was happening to them. And in that context, there was enhanced reputation of the healthcare professionals. There was improved morale and productivity of healthcare professionals as they saw patients, really improving, taking responsibility for their health, etc. There was also noted to have improved resource allocation and decreased healthcare costs. Because as you know, with our non-communicable diseases, if we could get patients to take responsibility for their health and do the correct things, we will see that decrease in healthcare costs, particularly at the tertiary level. So, for this talk, I am going to focus on patient-centered care in the doctor's office. We are not really going to go into at the hospital setting, and I'm also going to do it in this context that the patient we're dealing with has the capacity to make informed choices. So what does this mean in terms of in a doctor's office? So there's a trusted personal relationship. And again, later on, we will go into some of that, but really the relationship that the doctor has with this patient is, I would say, it's a more intimate, it's a more intense one that we are accustomed to. There's two-way communication. So it's not just the doctor giving advice, etc., but it's also the patient making known what are their values, what do they expect, what are they looking for, what are their goals. So it's a two-way communication, which means that both the healthcare professional and the patient is listening to each other, right? And communication, because that's the only way. And not only listening, but understanding, but taking into account. So it's a two-way communication. The healthcare provider sees beyond the immediate diagnosis. So this is not, diabetic. And we say we don't say these things. This is a patient with diabetes, right? So the healthcare provider takes a broader look at the needs of the whole patient. And it is really from the patient's lens. It is really from the patient's narrative. And that is something that we may not be so accustomed to doing, but that is what patient-centered care is. We are looking at it from the patient's lens and through the patient's narrative. Information is shared fully and in a timely manner. And so this was touched on before, but what we have to look at in the doctor's office now is the sort of technology-based tools that are available to help patients take ownership of their health care. So access to medical records. There are some places where a patient has an app and they can go on and they can access their medical record, they can access the results of investigations and be ownership of their medical record. I'll just use an example. This is in a hospital setting, but I had a friend who recently had an operation in the US. And for the family members, after they said goodbye, as you know, they were taken into the area for the operating suite, immediately on their phones, they were getting updates. So they knew when the operation started, when it finished, when the patient was transferred to recovery, and they were informed when you can come now and see the patient. And within 15 to 20 minutes of that operation being over, they were able to see the surgeon's notes, the anesthetist notes, everything. It was available. They knew exactly what had happened in that operating room. So tools that allow patients access to their medical records and their results, tools that allow them to schedule appointments. We just heard a presentation about that, right? Their use of apps. So now it's recommended use of apps that can track their BP, continuous glucose monitoring, their weight, etc. So they have these readings, right? And of course, you know, there's personalized medicine, which is based on genetics, metabolism, biomarkers, immune system, etc. So that is what patient-centered care look like in the doctor's office. So I was asked to talk on the ethical conflicts in patient-centered care, and it's really based on two colliding or competing ethical principles that need to be reconciled in the best interest of the patient. And the biggest one in patient-centered care that you will face in your practice is the ethical tension or dissonance between that respect for autonomy that we were speaking about, that shared decision-making, and your mandate to do what is best for the patient and to do no harm. That is where you're going to find the biggest sort of ethical challenges. Now, what are the methods of decision-making? So as we know, initially, and in some places, it may still be so, where there's this paternalistic or parentalistic or maternalistic, whichever one you want to say, where the healthcare provider, it's felt that the healthcare provider has the requisite training and knowledge to determine what's best for the patient. The patient has no input into decision-making, accepts what is advocated, and autonomy is disregarded. Now, the healthcare professional may be doing it from a place of beneficence, but still we recognize that this disregard of autonomy is really not the sort of way we want to make decisions. We have moved away from that, but we still recognize that in some cultures and for some people, they still want that sort of paternalistic, but we are saying no, you know, we have moved away from that. It results in dependency, right? The patient takes no responsibility or ownership of his own health. And so it's dependent on the doctor. And we say, no, that is not the way to go. So we moved away from paternalistic and we moved to the informed consent. And again, patient must be competent, whoever it is, to understand and to make decisions, right? Information must be given, full information, and that's very important, full information in a neutral way, because we know the way that you present information can influence a decision. So it needs to be in a neutral way where you are giving all the facts. The patient must be able to comprehend, and then it must be a voluntary decision. So there's no coercion, there's no inducement, there's no undue influence. The patient has voluntarily. And so the patient is given all the information needed to make an informed decision. However, this does not absolve the doctor from that principle of beneficence and non-maleficence, right? Although the patient is making that informed consent, you still have a duty to make sure that it is in the best interest of the patient. And so in patient-centered care, we have different models, and it's called shared decision making. And so it involves a collaborative process. There is full disclosure of all the information by the healthcare professional in a neutral manner, as I said, so you are not inducing or exerting any undue influence. The patient may do independent research, and you reach what we call a negotiated position. Now, we have to be aware that it may not always be what either party considers to be the best course of action, and there may be conflict with patient safety and treatment quality. And that's where the ethical tension comes in. So how do we go about this reconciliation of this, how do we get over this tension? Oh, sorry about that. So we have to look at it. We have to look at beneficence and non-maleficence, right? So we look at the clinical assessment. What is the nature of the illness? What are the goals of treatment? A lot of times when the patient and family and the doctor are at odds is because they have a different understanding of what the goals of the treatment would be. What are the treatment options and likely success? Are there any adverse reactions of the treatment? What are the effects if no treatment was done? In terms of respect for autonomy, the patient is competent, yes. Patient rights, what are the patient's rights? You have to take into consideration what are the rights, what are the preference. Information is given, what is the competence? And then, of course, we always have to look at the distributive justice. Are there any external forces, and what are the contexts? Now, in looking at this, I would say to you, ethical considerations are neither clear-cut, right, for most part. I mean, there's some instances where it's just quite clear-cut, right? We have a prem baby. Sorry for my examples, because I am a pediatrician and neonatologist. We have a prem baby, hemoglobin is 5, needs a blood transfusion, parents refuse a blood transfusion. That is a sort of clear-cut thing when you look at beneficence, non-maleficence, etc. And in a case like that, we will go to the courts to say, listen, this child needs that. So that's sort of clear-cut. A baby is at exchange transfusion, the parents are refusing it, we know what can happen, those are clear-cut. But in your practice, you're not going to get that sort of nice, clear-cut, thing. It's usually things. Now somebody's on and it's blocking. Okay, I've gotten it out of the way. All right, so this is a case I'll give you, and I want you to think about it, and we'll discuss it at the end. So you are seeing a 1-year-old boy for his well baby visit. He's due the MMR vaccine. Parents inform you that they do not wish the child to receive the vaccine, as they have read that it is linked to autism. Mother has a brother who is autistic and does not wish the same to happen to her son. Additionally, as far as they're concerned, measles has been eradicated in Jamaica. So I want you to think about it in the context of patient-centered care. How would you manage this case? Okay, so as I said to you, the big ethical thing is between that autonomy and your mandate to do what's best for the patient, to do no harm. So a lot of the conflicts will come there, but there are some other, what I call ethical considerations that we must be aware of. And this is based on the patient-healthcare professional relationship. So the sort of ethical consideration, patient-centered care versus privacy and confidentiality, patient-centered care versus professional competence, patient-centered care versus judging and justice, and patient-centered care versus health professional well-being. So we take them one at a time. So remember we said this relationship, we are looking at it from the patient's lens, from their narrative, right? And so when we are taking that history, we are getting a much more in-depth history than previously we may take. Because remember, we said the different areas. It's not just clinical, it's emotional, mental, spiritual, social, financial. So that patient will be giving you far more information, and we have to be careful how we cross the boundaries of privacy and confidentiality, both on what is elicited and what is disclosed, because the patient may think in the context of the relationship you have that they can't disclose everything. So we really have to think about, when we are doing this patient-centered care, that we establish boundaries and the patient knows about it. So for instance, in adolescent medicine, we, at the beginning, we say to the adolescent, listen, what you reveal to me will be kept confidential. I will not reveal it to your parents unless you have revealed to me that you intend to self-harm, to harm someone else, or commit a crime. So at the beginning, I am telling them what are the boundaries of the information that I will elicit and that you disclose or divulge to me. And I think it is something we have to look at when we are talking about this patient-centered care, because we know that sometimes even without patient-centered care, a patient may walk in and reveal something to you that makes you, it may be on the border of, do I need to report this or not? So I think it's important for us to upfront say what those and establish those boundaries. We have to look at the confidentiality of our notes, because if we are taking this kind of history, and again, we had a presentation of how you can separate who sees what, but for people who still have paper documents, what does your receptionist see? What does your nurse see? As we heard from the previous thing, gender-based violence, if you're writing that in your notes, how do you maintain confidentiality? So there are ethical considerations there. There are ethical considerations about you in this relationship going outside the area of your professional competence, giving advice on non-medical problems, spiritual dimensions of health, counseling. If this is not your area of expertise, please refer the patient. So you understand, you hear what the patient is saying, but please, there is that possibility of crossing that boundary and, giving advice where you shouldn't. Again, non-judgmental. Again, patients are revealing very private information to you. And we have to be very careful that the knowledge of the patient's circumstances do not cloud our clinical judgment. For instance, if we have a patient who is, non-compliant, we know they're doing, whatever, that this does not cloud our clinical judgment. And the last thing, the healthcare professional well-being. Remember, there is loss in this sort of relationship. You are losing the protection of professional detachment, right? There's blurring of boundaries. You have to be very careful, particularly with doctors now on social media, and so patients are following you on social media, whatever. You have to be very careful of that blurring of boundaries, that loss of protection of professional detachment, because how you counsel a patient that you do not have an attachment to is quite different from when you know personal things. And so I had said that case, okay, what are the ethical things we have here? The child has diminished autonomy, is in need of protection. Parents are autonomous agents, right? They're determined for the child. In terms of doing good, we know that fully immunized prevents disease, harm, measles, there's pneumonia, there's encephalitis, mumps, there are orchiditis, which can lead to infertility. In terms of justice, that patient, if we have many patients who are not immunized, it can be a source of outbreak. We know we can have imported cases of measles. Remember rubella in pregnant women, and also the duty to report. So quickly, how you handle it, review the information on the link between MMR and autism in patients. Dr. Wakefield work has been discredited. Subsequent studies show no link between MMR and autism. The autism incidence is similar in countries that use MMR versus the single measles vaccine. You discuss the benefit of immunizing the child, risk of not doing so, discuss side effects of vaccines, vaccine imported cases, travel, explore whether mother's brother is really autistic or is it something else. Work with the parents. Communicate. You may agree to delay the vaccines while collaborative discussions occur, because remember, you can get it in between 12 to 15 months. These are my references, and thank you.
Thank you very, very much also, Professor Helen Trotman-Edwards. You've left us with a lot to think about, to ponder on where we are in the scheme of things when it comes to dealing with patient and decision-making and patient-centered care. We definitely haven't anything like that, that example you gave us of your friend. That's amazing. We can only hope and pray. We're in the dinosaur stages when it comes to that.
Yes, I was blown away. The surgeon's notes were available 15 to 20 minutes after.
Right now we have to fight to get those, dear Lord. Thank you so much. We learned a lot from you today. And I think, I'm not sure if I'm supposed to introduce CariMed or if at this point in time, I will hand over to Professor Marvin Reed. Professor Reed, Sophie, is it your turn? Is it your time?
I'm not sure. Is it my turn?
I think you could just go ahead then. Professor Reed is supposed to, from CCFP-Regional, is supposed also to come on board. Marvin, can I hand over to you?
Good afternoon, rather. My job is to really take you through the last session of this program. So on the agenda here, I have a sponsor's presentation. Is that you, Sophie?
Yes, it is. Good
Please go ahead.
afternoon, everyone. I'm so sorry my background is noisy. It's raining, but I'm sure we will not complain because we're at the dam school. But let me just say happy World Doctors Day to all our doctors. And we just really want to celebrate you and celebrate the work you do. This afternoon, we will be presenting the mechanism of action for our VMADA. And as we all know, it forms a part of the 4 pillars in managing heart failure with reduced ejection fraction. Just want to remind persons or remind doctors that you do not give VMADA with an ACE or an ARB. And when you're transitioning from an ACE to VMADA, that you need to ensure that there is a 36-hour washout period because of the risk of angioedema. All right. And I also wanted to just remind that our VMADA presentations are all on the National Health Fund, and the tablets are not scored. So please remind your patients not to try and cut it. The higher the presentation, the more subsidy, and therefore it will cost them less. All right. So I'll hand over to Samuel now, who will show the mechanism of action video, and also he will highlight the reverse reverse remodeling in heart failure, which our VMADA has been proven to demonstrate. All right, Samuel.
Heart failure is a serious condition leading to inadequate perfusion of the inner organs. Two neurohormonal systems, the renin-angiotensin-aldosterone system and the sympathetic nervous system, initially compensate by regulating water and sodium retention and inducing vasoconstriction. In the long term, however, they become detrimental. Currently available treatment options aim to inhibit these two systems. Another treatment approach focuses on the body's own cardioprotective mechanism, the natriuretic peptide system. Natriuretic peptides are released directly from the heart or the vessels to induce vessel dilation and thus unload the heart. As the natriuretic peptides are degraded by the enzyme neprilysin, the beneficial effects of the natriuretic peptide system are limited. Therefore, blocking neprilysin is a promising treatment approach in heart failure. However, neprilysin inhibition alone is not sufficient, as neprilysin also degrades the powerful vasoconstrictor angiotensin II and its precursor. The resulting increase in angiotensin levels outweighs the benefits of enhancing the natriuretic peptide system. Vimata, the first in-class angiotensin receptor neprilysin inhibitor, or ARNI, targets both the natriuretic peptide and renin-angiotensin-aldosterone systems. Vimata is a sodium salt complex consisting of the neprilysin inhibitor sacubitril and valsartan, an angiotensin II receptor antagonist. With its innovative multi-pathway approach, Vimata simultaneously enhances the beneficial effects of the natriuretic peptide system while inhibiting the detrimental effects of the renin-angiotensin-aldosterone system. In this way, Vimata restores neurohormonal balance and improves morbidity and mortality in heart failure patients with reduced ejection fraction.
Okay, so remember our presentations, the 50, 100, and 200 milligrams. Thank you.
Thank you, Sophie. So colleagues, we're going to be celebrating the third session, which is going to be focused on a panel discussion on the theme for World Family Doctors Day this year, which is Family Doctors, Heart of Healthcare. The panelists for this discussion include the president of the Association of General Practitioners, that's Dr. Donald Gordon, Dr. Pauline William Green, who was a former course coordinator for the Family Medicine's DM program at the University of West Indies, Dr. Kian Bookall, who is from the Department of Community Health and Psychiatry at UWI, Dr. Brian James, the current Medical Association of Jamaica president, Dr. William Brown, a former president of the Caribbean College of Family Physicians, and from the ministry, we have Dr. Carol Lord and Dr. Melanie Henry. The format for this kind of discussion is that I would allocate 5 minutes to each individual to make their pitch. And then after that, we will open up with a general question and answer component. So I'll invite Dr. Donald Gordon to make his presentation now.
Hello, are you hearing me?
Yes, Donald, I'm hearing you now. Go ahead.
I'm having a little problem here. Okay, I'll soon sort it out. Just give me a minute or two, please. Okay, thanks for your patience. Family physician as the heart of family care, healthcare. To say that family physicians are the heart of the healthcare it's really an understatement, because as family physicians, we provide a lot of services, a lot of information. We provide counseling, we provide advice, we provide legal information at times, and basically we try to take care of most of the needs patients come to us with. On an individual basis, we monitor patients, we treat them, we advise them as to the best course of actions to take in terms of whatever decision they might make. Sometimes it might be a patient who has to choose between cancer care, whether it be radiotherapy or chemotherapy. Sometimes we advise patients on whether to continue with a pregnancy in cases of rape, or sometimes we have patients with advanced kidney disorders and they're pregnant and they want to make a decision as to whether they should continue with the pregnancy. Sometimes we also have to give advice in terms of competence, whether patients are competent in making certain decisions, especially patients who are advanced in age and they're approaching dementia. We have to advise the family the best way to approach it in terms of preserving these patients' dignity. We also have to determine as to whether what care some of these patients also need. Other things that we do sometimes, as we have to be the confidant for very important information. Sometimes patients, they are witnesses to criminal acts and it's unburdening them. And sometimes they come to the doctor and they want to know what is the best course of action. And sometimes, and they want to know that this information that they have delivered to us will stay safe. And we have to assure them that some of these information is we treat it very confidential. Oftentimes, as family physicians, we monitor the emergence of diseases. Sometimes we see the first pattern of disease coming forward, and we have to report this to the ministry. So, sometimes you also have to monitor patients on an individual level in terms of how they are caring for themselves and other matters like that. So, as family physicians, we do perform a very central role. I mean, it's a multifaceted role. We really do a lot of things for the benefit of the patients. So at the end of the day, family physicians are really the heart of patient care. And, it's a role that we take very seriously, and it's a role that we try our best to discharge as best as possible. All right, thank you.
Thank you for that, Donald. So I think you made the point fairly eloquently that if you look at the analogy of the heart, and that is at the center of wide distribution of services, and certainly family physician is sorted in there. The baton is not going to be passed on to Pauline, just for her brief comments as it relates to this particular topic. Pauline, what say you? Pauline, you're muted.
Let me take this out. I hope you can hear me now. Yes, I had a presentation. Can I share screen quickly? And I'm going to stay within the 5 minutes. If I can, Sean. If not, I'll start. So while, I hope Sam hasn't fallen asleep, but while he's allowing me to share screen, I'm looking for it, Sam. Not seeing the share screen.
Let you share. It's there.
Yes, please let me share. Okay, so in preparing for this, I looked at what Wonka wanted us to do. Wonka started World Family Doctor Day in 2020, and they had some information, particular pillars or goals that they wanted to do. Can I go ahead now?
Yes, you can.
Okay, so I'll just try and do that right. Away and share. All right, so briefly, I hope you can see my screen. And you can, Marvin?
I'm seeing you very well.
Okay, good. So
put it on slideshow to help.
It would help. I thought it was on slideshow. Okay, so let's do that. And all right, as I said, I'm not ready to stay with it.
All right, so that's great. Go ahead now.
Okay, so I wanted, as a medical student, I longed to join a specialty that would reach a wide range of persons. I wanted to help persons have a better life in the physical, mental, emotional realms. Initially, I thought about becoming a psychiatrist, but then a friend suggested instead that I become a general practitioner, since the persons I wanted to help went to the GP first. When I trained in a specialty of family medicine, I thrived on the tenets of comprehensive, continuous care. And now as a family physician, I'm even more passionate in offering holistic care from the womb to the tomb. So I continue to be intrigued by the mystery of family medicine. You never know what will walk through the door next. And I am just fascinated by what individuals present. Can you fast forward to 2016, when in the Daily Gleaner, Dr. Arna Brown-Morgan in the World Family Doctor Day supplement said, and I quote, "Family doctors are central to the provision of primary health care in Jamaica." So I looked at what Wonka said, and the pillars of the family doctors being perceived as the heart of healthcare is their long-term relationship, their holistic relationship, coordination of care, advocacy, and of course, education. So the long-term relationship, we are the first point of contact for patients, and we provide continuous comprehensive care. The holistic relationship, we are comprehensive. We have them in every area, physical, emotional, social, and their psychological well-being. And we provide coordination of care, where we serve as a central hub for patients' healthcare needs. In terms of advocacy, we help patients navigate the healthcare system and access the resources needed. And we are teachers. We educate patients on their conditions. We help them to know how to prevent chronic conditions and therefore to improve their lives. Thank you. Get out of this. Stop.
All right, thank you, Pauline, for that contribution. And I would just ask for the other presenter, which would be Dr. Ken Bookall. We're hearing it now from the younger ones, what their thoughts are.
All right, good afternoon, everyone. Well, I'll keep it nice and short. I'm pretty sure I'm not going to go 5 minutes because a lot has been said already and it's been very well said. I'll just add that in preparing for this topic, that I found that ambulatory primary care is dominated, as we all know, by chronic non-communicable diseases. And I would be bold enough to say that family physicians who are trained in, the biopsychosocial model are very important in managing these chronic non-communicable diseases. In fact, I would say that it's crucial because often primary care physicians who are not trained in family medicine might not apply this approach. And we know that this approach is very important in controlling your diabetic, your asthmatic patient, or your patient living with asthma. Your patients living with hypertension, often the psychosocial aspects of their lives contribute greatly to their how well control their high blood pressure. Further to that, in a paper by Cobblow et al. Entitled The Value of Family Medicine, it was stated that adding family physicians to a population is more health benefits than adding any other group, any other participants. And this Canadian paper, those trained in family medicine benefited patients with, particularly with congestive heart failure, asthma, diabetes, and dementia. They also state that there is benefit to the continuity of care, as continuity of care with a primary care provider increases. So as that continuity increases, and they found there are decreases in hospital visits, in emergency room visits, and there are actually decreases in mortality with our patients. We also affect the cost of healthcare. So as you have this longitudinal care by your family physician, then overall healthcare costs also decrease. So that's my 2 cents.
So you have introduced the dimension of economics, as well as some of the quality of life issues associated with provision of care. Dr. Brian James, Medical Association President.
Thank you very much, Marvin. I'm first of all very, very pleased that I was deemed worthy of actually being a part of this conversation. I'm thankful to you for inviting me. I'm going to claim the mantle of outsider in all of this, and I'm going to bring a perspective from a different angle. I've always only worked in hospitals across the country. So basically, from the way I look at things is that an expert, this is what somebody told me once, and I thought it was a great thing to start off with. An expert is a person who knows more and more about less and less until he or she knows everything about absolutely nothing. And the way I have come to look at family doctors is that they are the non-experts in the healthcare delivery system. And their issue, their position is that they know a lot of very important and useful information about just about everything. And they know who the experts are, who they can refer if it is outside of their level of competence. And as a result of that, the conclusion from me is that family doctors play a crucial role in promoting the health and well-being of individuals and communities. I look at family physicians as being allied to public health physicians, and family physicians are pretty much the custodians of the health and well-being of the individual and the family, whereas the public health persons are mainly for the community. I realize that COVID has done a lot of very wonderful things for me personally, certainly in relation to how I look at the healthcare delivery system. And I think I used to be neglectful of, like public health people and primary care people until COVID hit. And 2 things happened. One is that I had a lot of time at home to think about and away from others to reflect on all kinds of very important things. And I did come up with something very, very similar to what Wonka has come up with, that family physicians are in fact the heart of the healthcare delivery system. I don't want to go through, Dr. Williams went through the pillars, and she taught me in community health when I was a student. So she has done what I was going to say. I'm going to just end by telling you, in my view, going forwards, the central objectives of the Jamaican healthcare delivery system should be towards integration. To my mind, there is now a gap, an integration gap between the primary care physicians and the secondary care physicians. And there really should not be a gap between your heart and the rest of your body. That is not good for health. And in my view, we should electronically integrate both systems. Electronic health records is not HER, it should be EHR. We should develop and implement an appropriate network to share information and share the processes, like, for example, investigations. COVID showed me that there is a huge deficit in something like getting a test done and getting the result if you are in primary care. It's difficult in secondary care, but in primary care, it is prohibitive. Communication, the referral system should be improved. I hope we're going to have some discussions on that. There ought to be significant and well-developed feedback mechanisms between the secondary care system and the primary care system once they send a patient. And this should include some kind of mechanism for the primary care person to do follow-up, reporting of the public health data, healthcare financing. I hope we get some chance to look at that. And finally, the Data Protection Act and the family physician. This is an important current topic of discussion. Thank you.
Thank you for that, Brian. And if we were to extend your analogy even further, you focus a lot on the vascular bed and describe that there's several large atherosclerotic plaques that's obstructing the communications across the vascular bed.
Absolutely.
All right, I'll now invite William and colleagues. You can feel free to enter your comments in the chat. If you have a question, if you have comments, feel free to use that. We'll be opening for general discussions in a few minutes. William.
Prof, can you ask the to start my video? All right, good. I can start it now. Very good. Just seeing it for the first time. Well, thank you for this. Pauline has mentioned quite a few things I was going to mention. Long term, of course, we are the heartbeat of healthcare from time immemorial, and things are changing, so we should change to maintain the heartbeat of medicine, how we practice medicine, how we deliver medicine to the public. She mentioned long-term communication. We have our patients. We build these long-term communications with them and the relations so we can know more about their lifestyle, their social conditions. She mentioned holistic approach. She mentioned the care coordination, advocacy, and education. And our dedication, compassion, expertise make us the heart of healthcare and a trusted source of support for patients. But things are changing. If we want to remain the heart and the backbone of healthcare, then we as doctors have to move forward. And one of the forward, we have to be comprehensive and compassionate as always, but we have to humanize, we have to have the humanization of primary care, which means that family physicians should be more involved in prevention and healthcare, and not just work as supervisors and gateways to secondary services. That's what Brian was talking about. We just referring patients to secondary care, but we should re-emphasize our health, our preventative strength, and go more into prevention of diseases. Coordination is not at the level of the government only. Yes, the government has to coordinate and liaise between primary and secondary and tertiary care. I think within the primary healthcare, the doctors themselves, the general practitioners, there should be some form of coordination in terms of computer-generated databases that we can move from one end to the other. I think that's a challenging thing for me at this time, where you can coordinate with the other general practitioners in the community. If we do so, then we'll be moving from a patient-centered, family-centered to a more community-based. And that this changing the approach from a family-centered caring family doctor to a community-based. We can't get up and look at the community, which the public health doctors do already in the clinics and all that. But within the private sector, we can have our databases so we can coordinate amongst each other. And then to use the capacity of the private sector doctors as co-workers to help family doctors in treating patients. The information technology is a challenge.
And this has to be managed properly in family medicine programs. And the referral system will be seen to be flowing nicely or flow-oriented, which will facilitate the implementation of processes of this model around the electronic health record. A lot has been said. But finally, I'll say the central issue is integration and comprehensiveness of the health process instead of central. We have to decentralize as much as possible if we are going to continue to be the heart of healthcare. Thank you very much.
William, thank you again for emphasizing some themes that have emerged in this discussion so far, a central one, that of integration. We will have a presentation from Dr. Carol Lord, who is with the Ministry of Health and Wellness.
No, Dr. Prof. Reed, just want to say that I think you have an older program. Dr. Lord and Dr. Henry both indicated that they would have loved to be with us, but they both have to be overseas at this time for different reasons. But I know that themselves and also the CMO are very interested in family medicine, family doctors. And I know that the Ministry of Health at present is looking at primary health care reform. And I'm certain that at another opportunity, they will share with us how they see the value of family doctors in the healthcare system.
So that's Elaine. All right, so the floor is now open. So there are certain themes that emerge from all the presenters, and I think I'll just summarize them. They actually fit relatively well in the pillars that Dr. Williams Green highlighted, which is that of comprehensiveness, long-term relationship, a theme of integration, a theme of health financing came about, as well as the fact that family physicians seem to have a particularly unique role in managing the chronic non-communicable disease. That was the point that was being made by Karen. So colleagues, the floor is open. There is a question and answer component. But while I continue to monitor that Q&A to see if there are any suggestions from the audience with respect to the overall discussion, with respect to the overall theme, may I be so bright as to pose the question to the panelists to say that essentially we have had presentations today that looked at the relative capacity or role of IT, information technology, in bridging the communication gap. The challenge we have is that that's a potential, meaning we anticipate that that will happen very shortly, we go. But what can we do, in your own opinion, to actually do that now?
Should I take it, Prof?
Yes,
Okay, go ahead. Go ahead.
Go ahead, Sam.
Let me just hold on. I thought Professor Winston Davidson's presentation was very, very intriguing. The whole business of the doctor on call, and there are other platforms, I'm sure. If you drive around Kingston, there at least one I know of in Barbican, there's a drive-in clinic as well, even though that's not necessarily an e-service. But the population, especially after the exposure to COVID, realized that there are other ways of accessing a doctor. They still need the family doctor, and they still want that togetherness, that listening ear, the patient-centered care that Dr. Trotman mentioned. However, it has to be done at a different level, technologically. So they want to use your WhatsApp. In my office, we have to use WhatsApp because patients are at work and they want their report. But there's an issue of how do I send you your pap smear report by WhatsApp? You never signed to say this was okay, but you thought of it all of a sudden. Eh? So we have to plan for that. There are those who are overseas, many Jamaicans in Cayman, wherever, they come here for medical care, they do their blood tests and they want their results. So sometimes you communicate by phone to them or video or Zoom. So there's a bit, so we are actually giving consultations by video calls. And so you are the family doctor, and the relationship, as far as they're concerned, has not changed. You're still the one who's coordinating. And let me just hasten to finally say, sometimes you have a patient in your room, but you have the whole family online on video call, and you are having to address the issue. And I didn't give you all my presentation. I wanted to focus on patients with dementia. I find treating dementia patients and their caregivers, because you're actually treating caregivers, an issue. So the technology is useful in summary, but we need to know how to manage it. That's my take.
Prof, you're muted.
Thank you so much. Sam, you wanted to say something? I saw your hand went up briefly.
Sure. I don't know if this could add to the conversation in any way, but a question. When you go to do some of these tests at labs, do the labs email them or send them electronically to the patients? And if the labs do that, do you sign at the lab to say, I give you permission to electronically send it to me? Just to assist the conversation, hopefully.
Sure. So as I said, Prof. Davidson and Prof. Trotman-Edwards spoke to some of those issues in their presentation. I was now looking, so that's the patient to doctor communication, but I was more interested in colleagues to colleagues communication. So right now, many of us in primary care will often get referrals from health centers, well, more so from outpatient clinics. Or sometimes we in our turn will also write referrals to various physicians for varying things. And the challenge is that many times things get lost. And the question then becomes, how can we think of improving those sort of what I call bilateral communications between different stakeholders in the health system? So Brian, for example, he's at the hospital, he's in his day, he does his fancy work, and he wants to alert us of some things. So typically what may happen is that they fill out this form, most of which the writing is very ineligible, so we don't know. You take up the phone, you try to call, and several things can happen. Either the doctor that is on the thing that you can make out is not on that service anymore, they can't find that person. You spend an hour going around from departments to departments. That's if you're lucky. Another time the phone will ring incessantly without an answer. And so you keep up. And so the question then becomes, sure, we will solve these issues when all of us are on one platform, but tomorrow, if Brian is sending me a patient, how can we improve that communication? Should we, for example, ask that the doctors put a contact numbers on those referral forms when they're sending it to us, so that if we have any further clarifications we can call? Should it be that they have a central point that we call to the hospitals to find out if something is happening? As physicians as well, we often get requests from patients to say, okay, they can't afford our fees anymore. Can we refer them to the health center so they can benefit from the no user fee policy and the drug? We send them off with the letter. They may come back a year later. We don't know what has happened in the interim. So those are some of the practical things I was thinking about. Brian, any thoughts?
Yes, I actually do have some thoughts, but I saw Dr. Bookall wanted to say something.
Dr. Bookall, you wanted to say something. Your hand is up.
Yeah, sorry. I was thinking along the same lines, but in my mind, we work best when we know each other, right? So I think that if there was a way in which we could improve knowledge of knowing each other, then it might help the relationship. Because think about it, if I have a patient and I need to send him to an internist, the first one I'm going to call is one I know. The one I know will be the one that would also respond to me if I call him. But if I go to some unknown doctor in the hospital, they don't care about me. Who are you? Right? I don't know them.
Sure.
So I think we have this, we're detached from each other. We don't have enough things that would kind of help us mesh together. And that's just one aspect. I know there are many, but that's the one that came to mind.
Right, and that's helpful, except that many times the referrals that you get, so the referrals that you send, to a large extent, you really don't have control over the final destination, especially if you're interfacing with the public system. If you're interfacing in the private system, you have complete control. So if I'm sending it to an internist in the private system, I have complete control over that process. If you're sending somebody to accidents and emergency at any of the hospitals, or you're sending them to the outpatients of any of the hospitals, or even sending them to another primary care facility, you really have no control over the process, which is something I always try to explain to the patients. And I'm just saying, system to system, they're really two parallel systems, the private system and the public system. But we need to talk to each other better so that the patients can benefit. I agree with everyone that technology is going to be the mechanism to help doing that. But the truth be told is the ministry is doing a pilot study with their technological solutions. There are several technological solutions out there in the private sector. And we may end up in a situation like the US, where every nook and cranny has their own IT platform, and none of them talk to each other very well. We may end up with that situation. So, in and of itself, the technology doesn't solve that communication problem, right? It's really us and the systems that we put in place that will help solve that. Dr. Carpenter put it on the table that, we should think about being advocates. And this is one of the areas, as Dr. James pointed out, that the vascular system is clogged. So how would we wish to have this solved? Dr. James, your time.
Yeah, so basically, as I was saying, I believe that that's the center of much of what ails the entire system. This lack of integration between the two systems, the siloing of both systems. And in actual fact, this is so important for the people who go between the systems, because they are the sickest people. And therefore, they need the most seamless kind of interaction between the systems. As you were alluding to, I've been thinking about, under the current system, what is the best way to temporize some kind of proper communication. And there is a system in the public hospitals of persons called patient affairs departments and officers and what have you. I believe that kind of department, as it's called, patient affairs, that kind of department could be the center of communication between the private system, let's call it a private system, because it also applies to community medicine in the government service. It's just not integrated. So between those and the hospital, they can get the referrals, they know who the persons are who are being referred to, they know who their team members are, etc. And so there needs to be a dialogue with the SMO, for example, of each hospital that allows for this kind of communication.
Sure. Sam, you have your hand up, and then I'm going to bring in Donald. Sam, go ahead.
Thank you, Prof. I think one of the things with the conversation that's crucial as well to remember is that technology has levels, and Jamaica is a developing nation based on the level of our technology that will dictate the level of the solution that we have that we can offer. I think in Prof. Trotman-Edwards' presentation, she mentioned the patient's ability to have their own records. The common denominator whether you know the internist or you don't know the internist or you can't control the internist that you're going to go to, is the patient. And where the patient can have their own records that they can contribute in their visit to the person that is giving them care helps. I say this from personal experience. Many, many years ago, as a nerd, I wondered why I didn't have my own records. And simply taking a photograph on your phone and figuring out a way to share it with your care specialist does a lot, because you go to the new specialist and I want you to do over the x-ray that was done a week ago because they don't have it. Right, so thanks again for letting me, just interact with the technology part. The nerd in me kind of goes off. Thank you very much.
Excellent. Before Donald come on the line, I saw a hand up for Richard Forrester. I think I gave you the permission to speak. Richard, do you want to contribute something?
Richard seems to have actually left the chat.
Okay, all right, great. Is it something that the Association of General Practitioners is going to put as their main activity for the next few months?
Well, following on what Sam has just said, in terms of patients having their own health records, a lot of patients nowadays, they do keep their own health records. They take pictures of the medication they're taking. So oftentimes when you ask them what medication you're on, they can actually tell you or show you on their phone what medication they're on. And more savvy patients are asking for a copy of their records. And as a physician, I often give patients a copy of their records. Something else that we can advocate for is that we can have more community Wi-Fi, free community Wi-Fi systems whereby which patient can communicate easily with the doctor or whoever might have their records, so that is something that we can also look at for more access for patients to have Wi-Fi contact and Wi-Fi, and also for doctors to share more of patients' information in terms of the records that they take, the blood tests, the x-rays and what have you. I think as doctors, we should share more because I certainly do share. More so whenever I am referring a patient to the public hospitals, because oftentimes the records get lost somewhere, and if the patients have a copy of their record, that certainly helps.
All right, colleagues, this is rather interesting. I think we have hit on something I think that we can actually be focused as a group of professionals working both in the public and the private sector. There was just one point that was raised to Brian's point about the patient advocates group. Right now in the chat, there is someone who wrote that the patient care person can't even talk to doctors. So, they would be utilizing that as an approach. It means that there are a couple of barriers that we would have to try and overcome. All right, colleagues, the truth be told, the 45 minutes that has been allocated for the discussion in this section is at hand. I like to stick to time. I know there are many things that we could discuss as it relates to this particular topic. And certainly what I'm
short point, please.
I'll let you in a minute. What I will task the various associations, that's Association of General Practitioners, the Medical Association of Jamaica, and certainly CCFP will be there as an umpire referee to work with the Ministry of Health to see if we can't roll out some memorandum of understanding to help improve the situation in our benefit, for our patients' benefit for the very near future, until the technology matures enough that we can cross talk using that modality or that medium. Brian, you wanted to say a point before we close off the session?
Yes, so much of what we've discussed so far, there are implications for the Data Protection Act. It's really very important. The MAJ, where we are working with various groups, including the Ministry of Information, to actually have a webinar that speaks to this as it affects doctors. So within the next few weeks, and maybe a little after the conference, please remember the conference, June 8th to 11. But the Data Protection Act is an important little area that we have to navigate when we're thinking about these things. So I just needed to say that.
Yes, thank you so much for that point. And yes, we have been having a series of webinars. Certainly CCFP and AGP have been sponsoring a series of webinars looking at that Data Protection Act and how it affects us. So colleagues, it's indeed my pleasure to bring this session to a close. I thank you for your patience, your diligence, your perseverance in sticking with us. And I will now hand over to Dr. Aileen Standard-Olson, who will do the vote of thanks. Aileen?
Thank you very much, Prof. Marvin. I know it has been a long morning, early afternoon, but I think we'll all agree that it has been well worth our time. We have got a wealth of information, a lot of food for thought, a lot of things that we will continue thinking and talking about for much more time. So I just want to take just a little time to thank the persons who made this symposium or conference possible. First of all, of course, we must thank our presenters. I don't need to reinforce the wealth of information that was shared from Professor Alverston Bailey, Dr. Dingle Spence, Professor Peter Figueroa, Professor Winston Davidson, Dr. Karen Carpenter, Professor Helen Trotman-Edwards. We thank them all so much for taking the time out, and many of them were able to stay with us for the majority of the conference. We do appreciate their time, their involvement, and their contribution. To our panelists, Dr. Donald Gordon, Pauline Williams-Green, Kian Bookall, Brian James, and William Brown. We thank you so much for giving us, just piquing our interest on this whole issue of how, as family doctors, we can ensure that as the heart of healthcare, we are able to feed to all the tributaries, that there are no blockages between us and others. So thank you all very much for your participation in the panel discussion. To our moderators, Dr. Sophia Brickian, Dr. Arna Brown-Morgan, and Professor Marvin Reed, for seeing us through the day, for making sure that things flowed smoothly, and for guiding us so expertly. Of course, a conference of this nature cannot occur without sponsors. And we do sincerely thank all those who have been sponsors of the, especially today, Health Canada 2000 Incorporated, Abbott Nutrition, Arista Pharma, R.A. Williams, Indus Life Sciences, Ophthalmic Suites, Pompano Bay Surgical Center, Caribbean LASIK Center, Daisy Health Technology, Pacey Commodity through the PA Benjamin Group, Medimplex Jamaica Limited, Caramed, and Novartis. We thank you all so much for being with us today and making your presentations. We also thank Caramed through Mrs. Christian for gift baskets, which we will get to our speakers in due course. And would also like to take this opportunity to thank some persons who have already made contributions to the Beatitude Home, the National Health Fund, MSN Pharmaceuticals, Food for the Poor, have already made contributions. And I'm reminding you, it's not too late for you to go back to the flyer, look at the particulars for the bank accounts, and make a contribution towards our outreach for this year, the Beatitudes Home. Would very much like to thank our IT support, our very efficient, engaged, and always present Sam Heron, and all Allgate Solutions for the expert IT support that you always provide. It is not taken for granted. I know that you do work before as well as during the conference, and we do appreciate that. Just a word out to the team at the Gleaner Company for again guiding us through the production of our supplement. For those of you who have not seen it, it was in the Friday Gleaner, the financial part of the Friday Gleaner, as a pull-out supplement. I would invite you to avail yourself of it and to read some of the very interesting articles that are there. And I would also like to thank those persons who took out advertisements that supported the publication of the supplement. Our heartfelt thanks goes out to our administrator, Mrs. Lynn Thompson Hyatt, who in spite of personal challenges at this time, has always been there for us, has always remained engaged, has given us so much support. And without her, truly, this would not have been possible. The organizing committee, I want to thank the organizing committee led by Dr. Andrea Purai, who was the chair of the committee this year, but certainly persons from family medicine, Caribbean College of Family Physicians, and AGPJ were all involved in organizing this. I must say a special word of thanks to Dr. Seni Onanuju, one of our doctors of excellence, who was really instrumental and the guiding force behind putting this conference together. And we do express to her our sincere thanks. Also want to thank you, the audience, very much for being with us. At peak, I saw over 728, and I thank the over 500 of you who are still with us at this point. And really want to thank you for your support. And as COVID was a rough time, but one of the good things I think that have come out of it is the use of these virtual platforms for conferences, because it does open it to so many more people who may not be able to take the time out to physically come to a conference at a venue. If you look in the chat, you will see the link to the supplement. So if you take a picture or do whatever you need to do, you'll be able to get a link to the Gleaner supplement. So I hope I have not left out anyone. I want to thank you all very much and wish you all the best for the rest of your Sunday afternoon. If I have forgotten, either Marvin or Anna can jump in and tell me who I've forgotten.
I think you have done well. I think you have done well.
Don't think I've forgotten anyone. All right. So thank you all so much, and enjoy the rest of your Sunday and all
and
the
you
best
will
for
get
the
your
week ahead.
CMEs. Yes. Don't rest assured, everyone will get their CMEs.
You
rest
will.
assured. All right.
All right. Have a good afternoon all.
Good, good. I remember the MAJ conference in June.